today for the conference of the RSSDI BIHAR chapter, and heartiest welcome to everybody from the organizing team. To start with the proceedings, may I request our scientific chairman, Professor Dr. Vinay Kumar sir, to please come on the dais. I'll request our organizing chairman, Dr. Himshankar Sharma sir, to please come on the dais. I'll request chairman reception committee, Professor Dr. D.P. Singh sir, to please come on the dais. I'll request chairman of RSSDI BIHAR chapter, Dr. B.K. Singh sir, to please come on the dais. I'll request Secretary RSSDI BIHAR, Dr. Subhash Kumar sir, to please come on the dais. I'll request Organizing Secretary RSSDI Conference, Dr. Obaid Ali, to please come on the dais. And I will request our chief guest, Dr. Anil Virmani sir, to please come. Dr. Shehwal, please accompany him. Please accompany him. I'll request Chairman Reception Committee, Dr. D.P. Singh sir, to please welcome all the guests.
So I extend my warm welcome on behalf of the organizing committee, myself, Dr. D.P. Singh, bowing my head, all the guests who have come from the far-flung area from Jharkhand, Bihar, Patna, Purnia, and Darbhanga, all sorts of the places. Welcome to you, and this is the first conference of RSSDI at our Silk City, Bhagalpur. So again, this is our opportunity. This is just the inauguration of the scientific program. Our organizing team, led by Dr. Vinay Kumar sir, has given you the very academic fish that we shall see, and thank you very much, because we should be brief and we should complete within time. Thank you very much.
I'll request our organizing chairman, Dr. Himshankar Sharma sir, to please say a few words.
Good morning, all friends who are from outside, and all our request, they have blessed this occasion. I request Professor Abhilesh Kumar to please come forward. Professor Abhilesh Kumar to please come forward. And all the three on his side, Sudhir, please do come. Mahesh ji, आप लोग आइए, फ्रेंड में आइए. Kamran, sit in. Thank you very much. I welcome all my students who are here, and I think that they will just be requesting more to join quickly. We are going to start the programs. So thank you, friends, for being here under the patronage of my state chairman, Dr. B.K. Singh, and the whole team of the RSSDI BIHAR is here. I extend a warm welcome to all of them, and the most dynamic secretary of the BIHAR, that is Subhash Kumar, with his all old friends of JSS, Mysore and all that, they have come over here. They will be joining us very shortly. I am thankful to my friend and a very close, I will say a family friend also, Professor Anil Virmani, who is always here and who had been traveling with us nationally, internationally, and everywhere we go. So he is a giant, and he represents at this moment all the heads of the affairs in Jharkhand. So I extend a warm welcome to you, sir. I am thankful to Professor Vinay Kumar sir, who is the scientific chairman over here. He has travelled the whole night almost from Patna by road to be here on time, and he tried to be here. So thank you very much, sir. I extend the welcome. I extend the welcome of all the friends who are here, Shehwal, Ravi, Sadiq, and everyone over here. Virender, thank you very much for being here. And whatever you are seeing is the, mostly I will say, it is all done, and the two spines which are behind this is Dr. Obaid Ali and Dr. Kamran Khan. So let us give a big hand for them also. Thank you all very much. So now I just leave this.
Thank you, sir. I'll request our scientific chairman, Professor Dr. Vinay Kumar sir, to say a few words.
आज की प्रातःकालीन सत्र में मैं डॉक्टर विनय कुमार आपको भगदत्तपुरम के पुण्य भूमि में स्वागत करता हूँ। यह भूमि अपने आप में बहुत भाग्यशाली है और मैं अपने आप को बहुत गौरवान्वित महसूस कर रहा हूँ कि आपके जैसे विद्वान चिकित्सा क्षेत्र के चिकित्सक महानुभाव इस धरती पर पधारे हैं। इस RSSDI की जो हम लोग ये अधिवेशन कर रहे हैं, इसकी तैयारी हम लोगों ने मिलकर की है और आप लोगों को इस क्षेत्र की नवीनतम जानकारी उपलब्ध कराने हेतु हमने सारे प्रयास किए हैं। इसका लाभ हमारे स्नातकोत्तर छात्रों को तो अवश्य ही मिलेगा, हमें भी आगे इससे काफ़ी सहूलियत और सुविधा प्राप्त होगी। मित्रों, कल रात की भीषण बारिश में हमारे जो प्रयास थे वो कुछ धूमिल हो गए, लेकिन हमें लगता है कि आप उसे नज़रअंदाज करके हमारी जो बची हुई खूबियां हैं उसको जरूर सहारेंगे और उसकी प्रशंसा करेंगे। My dear friends, ladies and gentlemen, we are here to just exchange our views in the recent developments of diabetes, which have been the main killer across the globe. More than 7 crore people in India are suffering. Around 14 crores are in line. To prevent and to protect them is our primary goal and achievement. Our team, scientific here, has taken no stone unturned to keep you aware with the newer facts and figures of diabetes. And I hope you will be interested in feeling these joyous movements. May I now request the scientific secretary, Dr. Manish Kumar, to go ahead with the proceeding. Thank you very much, gentlemen. Please go.
Thank you so much, sir. I will now request our chairman of RSSDI BIHAR, Dr. B.K. Singh sir, to please come and say a few words.
Thank you, Manish. First of all, on behalf of RSSDI BIHAR chapter, I welcome all of you. Respected Dr. Anil Kumar Virmani sir. He is the National Executive Committee member of RSSDI, and he is the only representative from the Executive Committee of RSSDI. Welcome, sir. Our organizing team, excellent organizing team, excellent workers and promoters and everything. Dr. D.P. Singh sir, Dr. Hem Shankar Sharma sir, Dr. Vinay Kumar sir, and whole organizing team, Dr. Kamran, Dr. Rohit, and everyone. Please give a big hand to the organizers. I want to say one thing, that Vinay Kumar Singh sir said that the last night we faced a calamity. I want to express the feeling of the RSSDI BIHAR chapter to all of you, the organizers, that with this Ramdhari Singh Dinkar point, that have gone bigger as such jag mein, टिक सके आदमी के मन में, है कौन विघ्न ऐसा जग में टिक सके आदमी के मन में। खम ठोक झेलता है नर पत्थर के पर्वत के जाते पाँव खड़, मानव जब जोर लगाता है पत्थर पानी बन जाता है, पत्थर पानी बन जाता है। With these words, I express all good wishes and best wishes for coming scientific session of this RSSDI. Thank you very much.
Thank you so much. May I request our Chief Guest Dr. Anil Virmani sir to please come and say a few words.
Good morning, friends. Honorable Chairperson of the RSSDI BIHAR chapter, Dr. B.K. Singh, Organizing Secretary Dr. Hemshankar Sharma, Dr. D.P. Singh, Professor Vinay Kumar Singh, Dr. Kamran, Dr. Abed, other dignitaries, Dr. Manish, and other dignitaries on the dais, and dear friends. It's an honor to be here today in a place of learning, right in the portals of a medical college under the name of Jawaharlal Nehru Medical College, to start this wonderful journey of the RSSDI conference today. Professor Vinay Kumar talked about the rain and tufan that happened yesterday. I can only say, अगर आपके मन में अच्छे अरमान हो, करने का पैशन हो, तो किसी तरह के भी तूफान और बारिश कुछ आपका बिगाड़ नहीं सकते। Dear friends, medicine is evolving very rapidly, and every day when we get up in the morning, we see something new is happening in the field of medicine. It's like a wheel that is moving very rapidly, and unless we study daily and keep ourselves updated, we'll be thrown out of this profession. In fact, medical profession is the only profession that strives hard to wipe out its own existence by talking about prevention of diseases. It's the only profession where right from the first year of medical college till your death or till you do practice, you have to keep on studying. Otherwise, you don't know what is happening. And with the wonderful scientific program laid out before you in the next 2 days, my only appeal is to all the delegates who are sitting here, especially the postgraduates, please interact with the speaker. Please have an inquisitive mind and ask questions. Unless you ask questions, you can never learn, and the speaker will never go back happy. With these few words, I wish you all success, and I'm again very honored to be here today. Thanks to my dear friend Dr. Hemshankar Sharma and Dr. B.K. Singh. Thank you, sir.
Thank you so much, sir, for your inspiring words, and heartiest thanks from the organizing team for taking out the pains to come here. May I now request all the dignitaries to please join for the lighting of lamp.
देवैः
Thank you so much. May I request all the dignitaries to take place in the audience, and to start with the scientific proceedings straight away. May I request the chairpersons for the first session, Dr. Subhash Kumar, Dr. P.V. Mishra, and Dr. Virender Kumar, to please come on the desk.
Secretary RSSDI BIHAR, I welcome you all to this morning session, and it is a proud moment that my college alumni Dr. Sumit Sankar is presenting his first talk as an opening batsman, and he is one of a pride for Bhagalpur, being a TM cardiologist. It is a great help for the city that a person of his stature is serving the motherland and people of Bihar. So really it is an honor for all of us to hear Dr. Sumit Sankar. So without wasting any time, I request him to start his presentation.
Good morning, everyone. Actually, it is an honor for me to stand here and deliver a talk in front of such a noble audience and learned people. Okay, I'll start my topic. My topic is diabetic cardiomyopathy. So, what is diabetic cardiomyopathy? Diabetic cardiomyopathy is defined by the existence of abnormal myocardial structure and Hello, am I audible? Yes. Okay, so it is defined by the existence of abnormal myocardial structure and performance in the absence of other cardiac risk factors such as coronary artery disease, hypertension, and significant valvular disease in individuals with diabetes mellitus. So what is the epidemiology? We already know India is going to be the diabetic capital of the world, or this already is. Okay, so diabetes affects 180 million people worldwide. 2/3 of the patients with established cardiovascular disease have impaired glucose hemostasis. Affects 30% of heart failure patients. Every 1% increase in HbA1c leads to an 8% increase in heart failure. So in type 1 diabetes mellitus, each 1% of increase in HbA1c was linked to 30% increase in risk of heart failure. In type 2 diabetes mellitus, each 1% increase in HbA1c is associated with 8% increase in the risk independent of other risk factors including obesity, smoking, hypertension, dyslipidemia and coronary artery disease. So suggest that graded increase in glycemia is a powerful promoter of heart failure. Now what are the risk factors for diabetic cardiomyopathy? Hyperglycemia, systemic insulin resistance, impaired cardiac insulin metabolic signaling are major clinical abnormalities in diabetes mellitus, and all are involved in the pathogenesis of diabetic cardiomyopathy. Now what is the pathology? What happens? So there is thickening of the capillary basement membrane, followed by myocellular atrophy and hypertrophy, myocardial and interstitial fibrosis and fat droplet deposition. So these early changes, there is early changes in diastolic function which affects up to 75% of asymptomatic diabetic patients. Then there will be collagen deposition, presence of AGEs, and late compromise of LV systolic function. So starts with the diastolic dysfunction, ends up in systolic dysfunction. So what is the evolution of diabetic cardiomyopathy? So clinical heart failure. So patient gets diabetic cardiomyopathy, then how do they evolve? So like I told, diabetic cardiomyopathy is usually asymptomatic in these early stages of its evolution. One of the earliest manifestations is LV hypertrophy and decreased LV compliance, characterized by impaired early diastolic filling, increased atrial filling, and prolonged isovolumetric relaxation. LV dilatation and symptomatic heart failure occurs after the development of systolic dysfunction. Again, hyperglycemia. What happens in hyperglycemia? There is excess AGEs and reactive oxygen species formation with deactivation of nitric oxide, myocardial collagen deposition, and fibrosis. So diabetes, this is a very common slide which all of us know about. That is, diabetes leads to hyperglycemia. Hyperglycemia leads to through various channels, leads to increased oxygen radicals, increased oxidative stress, and oxidative cellular damage. So that was hyperglycemia. Second is the fatty acids. So there is impaired glycosuria, pyruvate oxidation, lactic uptake results in apoptosis. There is alteration of myocardial biogenetics and contraction relaxation coupling. The third is protein kinase C. There is activation of DAG and PKC, signal transduction pathway, which leads to reduction in tissue blood flow. So not just the tissues are hypertrophied or atrophic, there is also reduced blood flow and increased vascular permeability, alteration in neovascularization, and enhanced extracellular matrix deposition. The fourth pathway which is involved everywhere in all cardiac system is the RAS system. So there is activation of stretch receptors in heart which activates RAS and sympathetic nervous system, which ultimately leads to cardiomyocyte hypertrophy and apoptosis. The fifth mechanism involved is aldosterone-induced fibrosis. So myofibroblast growth with interstitial and focal perivascular accumulation of collagen. Another which is the proposed mechanism is the hypoxia-induced factor 1 or vascular endothelial growth factors. The HIF-1 alpha activation via hypoxia bar free radical, which is the main mechanism of diabetic cardiomyopathy, induces angiopoietin, platelet-derived growth factor beta, and vascular endothelial growth factors. So in diabetes, VEGF and its receptors are decreased significantly, leading to impaired angiogenesis. Now, ultimately, the endothelial nitric oxide production is impaired. So this nitric oxide production impairment leads to endothelial dysfunction, or endothelial dysfunction leads to reduced nitric oxide production. So increased vasoconstrictor prostaglandins, glycated proteins, endothelium adhesion molecules, platelets, and vascular growth factors, which enhances vasomotor tone and vascular permeability and limits growth and remodeling. Autonomic neuropathy. So there is decreased sympathetic parasympathetic myocardial innervation and impaired coronary resistance vasodilator response. There is also impaired vascular diastolic filling. So this is the same mechanism in a pictorial representation, all the things which I told, that is hyperglycemia, hyperlipidemia, hyperinsulinemia, increased cytokines, RAS system activation. Ultimately, everything leads to diastolic dysfunction, systolic dysfunction, myocardial fibrosis, stiffness, and endothelial dysfunction. All these amalgamates into diabetic cardiomyopathy. So what are the stages of a diabetic cardiomyopathy? So stage 1 is diastolic heart failure with normal ejection fraction. Stage 2 is symptomatic heart failure with combined systolic and diastolic dysfunction. Stage 3 is symptomatic heart failure to which hypertension, microvascular disease, or viral disease have contributed with no coronary artery disease. Stage 4 is symptomatic heart failure with contribution from multiple confounding, including coronary artery diseases. And we already know NYHA classification. So, which is class 1 is asymptomatic, class 2 is slight limitation of physical activity, class 3 is marked limitation of physical activity, and class 4 is symptoms at rest. So this is how we classify diabetic cardiomyopathy. Now it presents as a heart failure, so all of us we know how a heart failure presents. So just a brief summary, that is symptoms like there will be fatigue, weakness, reduced exercise tolerance, and may also present as arrhythmia and sudden cardiac death. Physical signs include tachycardia, raised AVP, and heart sound gap. Now, how do you diagnose? Just like any heart failure, we can diagnose diabetic cardiomyopathy. So X-ray, if the heart is dilated, can show cardiomegaly. ECG can be normal, it does not provide any significant diagnostic criteria. Then we can go for a 2D echo, tissue Doppler imaging to look for diastolic dysfunction, intravenous contrast echo, CT and MRI. Now on echocardiography, for those who don't know, we can diagnose diastolic dysfunction. A simple way to elaborate it is that E wave is formed during filling of the ventricles, passive filling, which is obviously more than the A wave, that is the atrial contraction. So E wave will be taller than the A wave in a normal. But in grade 1, what happens because of diastolic impairment of the LV, the filling is reduced. So E wave remains low and A wave becomes taller than the E wave. So that is reversal of the E ratio by less than 1. So that is grade 1. Eventually you can come down to grade 2, that is pseudo-normal. Grade 3, it is the restrictive pattern which is reversible, and grade 4 is fixed reversible. So as the grade increases, the severity of the diastolic dysfunction increases and reversibility reduces. Now what are the types? Like I already told, there are two, diabetic cardiomyopathy is two-phased disease. That is, it can present as a restrictive pattern with only diastolic dysfunction, or it can present as a heart failure with reduced ejection fraction, that is the dilated phenotype, or dilated cardiomyopathy. So all the features are almost same, barring insulin resistance and hyperinsulinemia, which is more common in the restrictive filling pattern type, and autoimmunity, which is more commonly associated with dilated cardiomyopathy, that is the heart failure with reduced ejection fraction. Heart failure with preserved ejection fraction has shown to have more of hyperglycemia, lipotoxicity, AGEs, and microvascular rarefaction, that is microvascular damage. So diastolic dysfunction in patients with type 2 diabetes mellitus is really the first marker of diabetic cardiomyopathy. Actually, in a small study with 114 patients with type 2 diabetes and controlled BP without overt heart failure, were prospectively enrolled 88 matched controls. So overall, the prevalence of diabetes was diastolic dysfunction was 47%. Of that, 33% had grade 1 diastolic dysfunction and 14% had grade 2 diastolic dysfunction. And systolic dysfunction was almost in 32%, which is found by a GLS. GLS is global longitudinal strain, which is a newer format of doing an echocardiography, where you calculate the strain variations of the heart. Now coming to the, now we have diagnosed. So how will you prognosticate? Like what is the prognosis of this patient once you have diagnosed with that diabetic cardiomyopathy? So you can cluster it into 3 forms. That is, cluster 1 is low comorbidities. So you can see the time since enrollment and patient with event, it is the lowest in cluster 1, that is with low comorbidities. Whereas in elderly with diastolic dysfunction, this cluster shows early highest number of early events. But as you follow the patients, the hypertrophic or with systolic dysfunction, eventually the systolic dysfunction takes over the diastolic dysfunction, and they will have the highest event as the time progresses. Now, how do you manage? So we already know how we manage heart failure, how do we manage diabetes. So all of us are well aware of all the drugs which is commonly used in heart failure, which includes diuretic, beta blocker, AC, ARBs, SGLT2 and whatnot. So I will be talking only about few of the important drugs which is involved in both diabetes and heart failure management. So what is important is glycemia control. So all the previous trials, the major trials, that is UKPDS, ACCORD, VADT, advanced trial, did not demonstrate improvement in macrovascular outcome with tight glucose control. The newly class of glucose lowering therapies such as GLP-1 antagonist and SGLT2 inhibitors have shown exciting results. We already know SGLT2 is the new drug for all therapies. So GLP-1 analogs in a randomized trial, that is the LEADERS trial, patient with type 2 diabetes mellitus and high cardiovascular risk treated with liraglutide had lower rates of cardiovascular death compared to those having placebo. And similarly, exenatide versus placebo, there was no overall cardiovascular risk benefit with the study drug. Oral semaglutide and cardiovascular outcome in type 2 diabetes mellitus, that is the Pioneer 6 study. In this trial, patient with type 2 diabetes mellitus, the cardiovascular risk profile of oral semaglutide was not inferior to that of placebo. So all the trials such as liraglutide, semaglutide and exenatide have shown non-inferiority to placebo. Whereas the most exciting group of drugs, that is the SGLT2, which has shown through EMPA-REG outcome and CANVAS studies, there was a relative risk reduction in cardiovascular mortality and hospitalization for heart failure in patients with type 2 diabetes mellitus with established or high risk of cardiovascular death. Declared TIMI, a study of SGLT2 inhibitor dapagliflozin versus placebo, reduced the rate of hospitalization for heart failure, were also observed in lower risk subjects with type 2 diabetes mellitus. Emperor Preserved, that is the only drug approved in heart failure with preserved ejection fraction, empagliflozin, reduces the combined risk of cardiovascular death and hospitalization for heart failure in patients with heart failure and a preserved ejection fraction, regardless of the presence or absence of diabetes. This is the most important drug in our armamentarium which we have for heart failure patient with preserved ejection fraction. That is the empagliflozin. So SGLT2 lowers blood glucose level by promoting urinary glucose excretion. It also gives secondary benefits such as weight loss, diuretic effect and BP reduction. So it is not precisely known that how does this SGLT2 inhibitor lower the risk of heart failure and a favorable outcome. There are multiple proposed mechanisms or hypotheses which is not, the most popular one being that increased fluid loss driven by urinary glucose and sodium excretion lead to a reduction in intravascular volume and systolic blood pressure. This in turn reduce preload and afterload, leading to improvement in myocardial oxygen supply and vascular formation. So this is the most popular hypothesis. It is not clear how it does, what it does, but it is clear that it does. So others suggest that SGLT2 inhibitors through shift of myocardial metabolism towards ketone have favorable effect on cardiac energetics. So these are the various trials that is I have already told about EMPA-REG outcome CANVAS trial, declared TIMI, and the GLP-1, that is LEADERS, SUSTAIN, EXCEL and HARMONY outcome. Now dapagliflozin in heart failure with preserved and mildly reduced ejection fraction, that is the DELIVER trial. So in the DELIVER trial is an international multicentric parallel group event-driven randomized double-blind in patients with chronic heart failure with reduced ejection fraction, that is EF less than 40%, comparing effect of dapagliflozin 10 mg versus daily versus placebo in addition to standard care. So this is an ongoing trial, which most likely if empagliflozin shows, so dapagliflozin should also come as a positive drug. So that is sugar control with extra drugs, that is SGLT2 and GLP-1. The second point is blood pressure. So ACCORD trial have shown us that intensive BP lowering type 2 diabetes mellitus, there was no demonstrable survival benefit with intensive BP reduction, that is BP less than 120. So that should not be our target. Why? Because intensive BP was in fact harmful and led to increased incidences of syncope and hyperkalemia. So what is this known as? This is known as a U-shaped relationship between BP and cardiovascular in outcomes in type 2 diabetes mellitus. That is, systolic over 150 is bad. I'll finish fast. And less than 110 is also bad. So this is a U-shaped curve which should be maintained in between the two. Lifestyle. Everybody knows lifestyle modification is as important as the drug. So what it increases, it includes weight loss and exercise programs. So what is recommended is at least 30 to 45 minutes of brisk walking, not slow walking, brisk walking, at least 5 days a week. And the other standard therapy, which I have already told, which includes AC, ARBs, and now ARNI, and furthermore diuretics or aldosterone receptor antagonist, and followed by the last therapy, which is CRT, when the patient is in failure with wide QRS complex more than 150. So this is just a picture of showing a GLS of 2.2 in a patient with suspected diabetic cardiomyopathy, which we in our center. Barring the conventional therapies, now what are the new targets? So just to elaborate, there are gene therapies which includes cardiomyocyte deletion of FOXO1, rescued cardiac dysfunction and preserved insulin responsiveness in mice fed with high fat diet. The other is modulation of oxidative stress. So several studies conducted in the past 40 years have explored and efficacy of coenzyme Q in reducing oxidative stress. So coenzyme Q treatment results in reduction of systolic and diastolic blood pressure in diabetic patients, acting as a vasodilator. Moreover, supplemental of coenzyme Q10 decreases cardiac inflammation, fibrosis and hypertrophy in type 1 and type 2. Okay, just to conclude, rapid increase in prevalence of type 2 diabetes mellitus is a global pandemic. Patients are at high risk of developing heart failure and dying prematurely, but the prevalence of subclinical cardiac dysfunction causes and the causes are uncertain. Improved glycemia control per se do not reduce the risk of developing heart failure, but newer pharmacological agents reduce cardiovascular complications, SGLT2 have shown to decrease heart failure related hospitalization. Weight loss is also an attractive option. Thank you.
Hello. A masterly presentation. You covered all the areas so well, including the trials, which was really eye-opener for all the evidences in support of SGLT2 inhibitors and about GLP-1 analogs. So I think we are short of time. So we'll go to the second talk and then
we can combine the
questions. Yeah. Okay. So
thank you so much. Thank you.
I think we'll invite the next speaker, who is none other than Dr. Sehwal Guha. I think he's one of national QL and a speaker of great repute. So, just introduction slide, please. Dr. Sehwal is a renowned cardiodiabetologist at Patna, and he has been attached with several trials, and he has some very renowned publications to his credit. So, without wasting much time, I think we'll go to his talk. Topic, please. Next slide. It is on evidence to practice. I think it's one of the most important topic we are going to hear. Over to Dr. Sehwal Guha, sir.
Thank you, Chairpersons. Good morning to all the dignitaries in the dais and dear friends. I was lucky to be in the opening team of RSDI Bihar in divided Bihar along with my Guru Ajay sir and my younger brother Anand Shankar who is here. And it's very satisfying to see the organization growing by leaps and bounds in the state. And I have been here in Bhagalpur as a speaker earlier in CCTSI, and I can assure all those who have come here for the first time as faculties that you will go back with, you will be zapped by the hospitality and you will go back with immensely memorable events and very sweet memories of this place. I will be talking about the role of long-acting insulins in diabetes, and so I have been covering the concept of use of long-acting insulins and how what we know in the real-world style is translated into real practice. We will be discussing about the ultra-long basal insulin as well as co-formulation. To talk about ultra-long basal insulin, we will first discuss why ultra-long insulins are needed, the whys and hows, and how they are beneficial for the conventional basal insulins, and how simplistically they can be used in our patients. Now the first question arises is why do we need basal insulin analogs at all? To look into that, we have to understand that what are the drawbacks of conventional basal insulins. The conventional insulins have poor approximation of the background physiological insulin secretion, and the onset of action is often delayed. Absorption is quite often erratic, and there is significant variability person to person and as well as within the same patient. And this unpredictable absorption leads to incidence of hypoglycemia, and hypoglycemia becomes a significant titration barrier, which is understood none other than the patient who has experienced it. So what should the ideal basal insulin should be? The ideal basal insulin should have a flat time action profile, should have minimum variability, should have a long half-life, preferably more than 24 hours, and should be very potent and predictable potency in lowering blood glucose level. I understand that the ideal insulin is still utopian, the concept of anything ideal is utopian, but we are gradually in the quest of looking for the ideal insulin. Gradually scientists are achieving drugs which are better, and if you can see here, right from the time of isolation of insulin, till the invention of various animal insulins, NPH insulin, glargine U100, glargine U300, and finally the degludec insulin. We are gradually increasing the half-life of the insulin, and we are gradually reducing the variability of the product, so making it more predictable, making the glucose loading more safe, and reducing the incidence of hypoglycemia. And that's how things are evolving over a period of time. In view of that, we have the latest molecule, the insulin degludec, where basically this is a conventional insulin molecule, and the threonine at the B30 position in the chain has been replaced by long-acting chain, making it very long-acting. And when it's injected in the skin, the phenol molecules get off from the dihexamer formation, leading to the multi-hexamer chain formation in the subcutaneous space. And then this multi-hexamer chain gradually breaks down after the diffusion of zinc molecules, and it causes release of single hexamers, which takes time to disassemble, and that makes it a long-acting insulin. And these monomers are gradually absorbed from the solution. So what are the evidence in favor of degludec which is not there with the conventional basal insulin? If we talk of conventional basal insulin, the first prototype of conventional insulin is glargine U100, which is still the most commonly used conventional basal insulin. The first difference which degludec had with this is a rapid onset of action, where onset starts within half to 1.5 hours, in contrast to glargine U100, where the action starts by 2 to 4 hours, and the duration of action is as long as 42 hours, whereas with the conventional U100 it's around 22 hours. So that is the basic difference. And we have seen the various trials, the RCTs like Begin, Switch and the Depot trials, and the real world evidence as is shown in the EU3 to type 2 diabetes, and all have shown consistently that the incidence of hypoglycemia, whether total hypoglycemia, nocturnal hypoglycemia or severe hypoglycemia, are lesser with degludec as compared to U100 insulin. Interestingly, if you see the A1C lowering potency at keeping the hypoglycemia risk constant, what we find, if you see the hypoglycemia is on the vertical scale, if you see a hypoglycemia at a constant level like 30% incidence of hypoglycemia, what we find is that A1C lowering of degludec is much better than U100 glargine at the same risk of hypoglycemia, meaning thereby that the A1C lowering potency is definitely better with a much lesser incidence of hypoglycemia. Also, the day-to-day variability we can see here as compared to degludec U100, the variability is much lesser. So that basically translates into better time in range and lesser time below range, as was seen by this CGM study. It showed that about 20 minutes extra per day the patient on degludec stays within range in time in range as compared to degludec U100, which basically means that and also the time below range, if you see that the patient on degludec, the time below range is much lesser as compared to patient who is on degludec U100. So significantly better time in range and lesser time below range with degludec versus glargine U100, which is not surprising. Now comparing it with the recent glargine U300, which is a more condensed form of molecule and which is much lesser volume is injected, which is slightly more predictable than U100, lesser variability than U100. Even as when compared with glargine U100, what we find is that the degludec action starts earlier, half to 1.5 hours as compared to 2 to 6 hours. This U300 is slightly more long acting than U100. The actions last for 30 to 36 hours, but degludec is still a longer acting. Further, its action lasts for 40 to 42 hours. Glycemic control is again slightly better with degludec as compared to U100. As we can see here, the A1C lowering is average is around 1.5 with degludec as compared to 1.2 with U300. Fasting control, sugar control, as shown in the BRIGHT study, is slightly better with degludec as compared to U300. And again, the change in rate of hypoglycemia and change in proportion with hypoglycemia, these two factors when analyzed were lesser with degludec, as was published in the confirmed study. They were lesser with degludec as compared to glargine U100. Not surprisingly again, the within day glycemic variability was better with degludec as compared to U300 glargine. As you can see here in the both graphs, degludec has approximately 40% lower within day variability glucose lowering effect compared to glargine U300. And if we see the day-to-day variability, again, as we have seen with glargine U100, here also, as compared to glargine U300, degludec has a lower day-to-day variability. This means lesser fluctuation of blood sugar, again translating into better time in range, and this translates into better adherence of therapy among the patients, because the patients find that their sugars are responding in a better way as compared to the conventional basal insulins. So, as has been shown in the confirmed study, the likelihood of discontinuation of basal insulin treatment was much lesser with degludec as compared to the conventional insulin. In fact, it was 27% lower as compared to the basal insulin. And all this lesser variability, along with the increased potency as well, because we have seen that the head-to-head potency was seen compared. Glargine degludec was seen to be 30% more potent than glargine U100, and that was that basically meant a significant lower daily dose, as this study has shown that when we are switching a patient from U300 to degludec, as was done in the BRIGHT study, that total dose requirement came down to about 23% lower. This was even recognized by RSSDI when they mentioned in their brochure catalog that when we are thinking of glargine U300, we need to give about 20% dose extra as compared to patients on glargine or patients on degludec. So if we talk of degludec, lower dose is required because this is more potent. So 10% lower dose if we compare with glargine U100, and about 27% lower dose required if we compare with glargine U300. And with that, whatever we had talked about, the lesser amount of variability, better time in range with degludec, obviously that entails lesser monitoring, lesser expenses on the part of the patient as far as glucose strips are concerned if he is doing SMBG at home, lesser bother, lesser risk of hypoglycemia. So that is one major advantage. So how can we simplify the use of degludec to our patients? When we are starting a patient on degludec, if it is insulin naive, it is customary that we can start with 8 or 10 units per day of a dose. And then when we are switching a patient who is already on a basal insulin, if he is on basal once daily insulin or basal component of basal bolus or a premix insulin, simply a 1:1 switch can be done. However, if the patient is on a much higher dose of insulin, like he is on basal BID or he is on glargine U300, a 20% dose reduction is needed when we are switching this patient to degludec insulin. So that is one important thing which we should keep in mind when we are switching a patient to degludec insulin. And titration is very simple. We can do plus or minus 2 units if the patient is above or below the target. And what we have seen, there is a large flexibility. The next dose can be given either 8 hours later or 40 hours later, and we can presume that that won't hamper with the insulin effect in that patient. So there is a large dose flexibility which is very suitable for patients who have a very busy lifestyle or for international travel in those category of patients. So what we find is it suits most of our patients, and it's maybe called as the ideal basal insulin because it's peakless. Now to talk about the co-formulation with degludec, the ideal asp is the only co-formulation of insulin. Others are premixed mixtures. We need resuspension before giving. However, this ideal asp is a co-formulation, so it doesn't need resuspension before injecting. And what we have seen, the evolution of premix from biphasic to biphasic analog to insulin degludec, what we find that the action profile is gradually improving. There is no dose dumping, there is no shoulder effect when we are shifting the patients to this insulin. And what we can find that certain limitations of premix insulin like variability in glycemic control, incomplete coverage for 24 hours, need for desuspension, these have been done away with when we are switching over to a co-formulation of ida-gasp. And because of its smooth action profile, various number of trials have been done with this molecules, and it has shown that the A1C lowering effect is definitely better. In fact, some of the trials have shown a superiority with this ida-gasp as compared to the conventional molecules. And across all the trials, what we find consistently is the incidence of confirmed hypoglycemia and nocturnal hypoglycemia is much lesser with ida-gasp as compared to all other insulins. This to a quick summary of the ARISE India study, a part of the Indian cohort who had taken part in the study. So this is a sub-study of the Indian cohort. 43% were on once daily dose, 56% were on twice daily dose of degludec ida-gasp, and it showed that the mean change of A1C from baseline from 9.8 to 8.2, and the mean change of fasting sugar was about 52 milligram per deciliter in the trial. And we have seen the reduction in hypoglycemia episodes. Hypoglycemias were negligible, especially severe hypoglycemia has come down to a large extent. And this basically translated into improved quality of life, which is the latest way of assessing any therapy these days. We assess the quality of life of a patient. It also helped in reducing the pill burden because patient is already on number of oral pills when he is advised insulin, and it has reduced the pill burden. The only question with degludec or ida-gasp was the price factor, because it was costly. Now price reduction has been done to a great extent in this, and we should remember that when we are talking of price of therapy, it's not only entails price of that particular drug, it also includes price of healthcare, price of visiting to the doctor, price of indoor admissions if needed. And when we are switching over this to a patient to ida-gasp or to degludec, we have seen that it entails a better control of sugar, so lesser hospitalizations, lesser complications, lesser visits to the doctor. So all those have reduced the patient's other costs like OPD costs or emergency room visits or inpatient costs. So Actually the cost of medication is definitely higher as compared to other basal insulins. But if we take the total cost into consideration, probably it adds on to the same, or even it can be lesser, because the patient is having lesser complications and lesser number of hospitalizations when we are using this form of insulin. So to summarize, when we are talking of IDEC-AS or even degludec, we can assume that our patient will have lower hypoglycemia, better meal time flexibility, as he is on a simpler regimen which is much easier to explain and much easier to follow. There is a convenience of device. He is having only one device and he can intensify his treatment with just one insulin and one device, and he can have a better quality of life, since we have seen the flexibility of dosing of 40 hours. So patient can take his next dose 40 hours later and then the scheduled dose, and still he can be certain that his insulin effect remains the same. And we have seen how it reduces the complications and the admissions, in-house admissions, and that becomes cost effective in the long run. And obviously all this with a better control of fasting in PPG and sugar and A1C. And we can use this insulin in all type of patients, whether the patient is uncontrolled on OADs, uncontrolled on basals, uncontrolled on premix, or patient on basal bolus therapy. We can use this in all patient types, whether insulin naive patients or type 1 or type 2 diabetes, elderly patients, patients with renal hepatic impairment, or patients with other comorbidities. So thank you for patient listening, and we will take up the questions. Thank you.
Yeah, it was a wonderful presentation, and we are much wiser about ultra long acting insulin and its benefits. Definitely insulination is a nightmare for the physician as well as for the people living with diabetes. So these are one of the most convenient insulin which can be easily started and titrated. I think we had a good learning of this newer type of ultra long acting insulin. So I think we can go for a quick question and session, because we are already 1 hour late of our session. So if there is any question, I'll request the speaker, Smith, also to come forward. Yeah, sir, please. Virmani, sir. Mic, please. Mic to the sir.
So I'm not aware of the exact pharmacokinetics of that.
You know that dose required is not the same.
Yeah.
But even though we are using 300 U300 glargine, to get the same fasting plasma glucose reduction compared to U100, the dose is more. Why?
Why is it not responding?
No, it's not a question of responding. The problem is U300 goes into the subcutaneous depot and it is released very slowly. So to get the same fasting plasma glucose as U100, it requires a higher dose and a longer time. Always slower. That's the problem. So I think the only use of U300 is when you are using very high units of
To
glucose.
reduce
That's
the dose volume.
Otherwise, not for, there's no need to convert from U100 to U300 on a routine basis. Absolutely fine. U100 is wonderful.
Any more questions?
अरे PGs को बोले ना क्वेश्चन पूछेंगे क्या कर रहे हैं?
Sir,
Professor Virmani asked whether the postgraduate students are going to ask.
I would like to.
One question to every speaker.
Or otherwise the speaker will ask questions to you.
Sumit, come over.
If some postgraduate.
Dr. Sumit,
Before he asks a question, I would like to ask a simple question, a small question from Guha sir. Sir, consider a scenario of a patient having comorbidity of hypertension, cardiomyopathy, and diabetes. Diabetes is uncontrolled. We are having full basal insulin. It's fasting glucose is not controlled, and patient is going into recurrent hypoglycemia. And at the same time, the HbA1c is not controlled. The same patient is having a poor control of the blood pressure also, and having a recurrent fall due to hypotensive amylase. Do you promote any switch in this type of patient, keeping in mind that the fall is there, poor glycemic control is there? do we have any correlation with the basal insulin control in these group of patients? Do we quantify those falls into a hypoglycemic event or a postural hypotensive event? Do we have any method to quantify those?
I think your question just in two parts. The fluctuation of blood sugar is one different aspect. The fall in blood pressure, I don't think it's related to that. It's a different aspect altogether. First, I would inquire which insulin the patient is on presently. And the next logical thing which all of us would agree is in such type of a patient is we'll do a CGM. To see when the patient is having hypoglycemia yet he is having a high A1C, we must assume that there must be some time above range which patient is having, which is preventing his A1C to come down, and despite having hypoglycemic episode. So we would do a CGM study, see the level of fluctuations, and preferably shift to a basal insulin with a more stable action, and see, because when we are talking of a patient who is having hypos and still his A1C is high, so there must be some phases in his 24-hour cycle where the sugar levels are high. Probably it would be a postprandial peaks would happen. So we would need some ultra-rapid insulin meal time to take care of that with a basal insulin. I think that should take care of the glucose part. The blood pressure falling is a different aspect altogether, which is beyond.
I'll invite Sumit to respond to that.
I think respond better.
Heart failure patient with fluctuating blood pressure. Can you be quick with one two-liner?
Heart failure patients with reduced ejection fraction, the first line as of now, I think is reduced blood pressure. I think we should always start with ARNI in a low dose, as long as they tolerate. That is the best drug to be added in heart failure patients.
Yeah.
And gradually titrate the dose.
Very on spot. So I think insulination is a big.
As a practicing diabetologist also, I would like to add an SGLT in that patient.
Yeah. So insulin is a problem for many of us who are not using it on the right time and the right place. I think we should have this session much useful, because the insulin which Dr. Sehwal has just discussed is very easy to start and to titrate the dose. For that matter, any basal insulin are much easier. So that is one point, and we are going to have a very exciting workshop on insulination, as well as more on lifestyle modification. PGs of medical college have prepared a very nice presentation. So I invite you to attend that workshop also after 11:30. So it will be a good experience for all of us who are here. So I think we have done with this presentation, so we close this. Thank you. Last question, please. Question.
Can we use diabetic insulin in acute cases? Why I am asking, because in acute cases, suppose patient is having infection and we get some moments when infection is controlled, and then by that time the requirement of insulin falls dramatically. So in that situation, if we are using an insulin which is having a half-life more than 42 hours and suddenly insulin requirement decreases, can it cause hypoglycemia in that events? In that situation?
The dictum of teaching is to forget basal insulins in ICU. Right.
Yeah, exactly.
So the role of insulin comes only in step-down therapy when you shift the patient from ICU. If the insulin requirement is very high, in that case we give a small dose of a basal insulin to reduce the dose of the rapid action insulin. Otherwise, within ICU normal. Sir.
I think we should make it clear to the postgraduates that basal insulin is not the only answer to the treatment of diabetes.
Right.
It needs to be substituted with either bolus insulin or oral drugs. You just can't treat diabetes only on the basis of basal.
Sir, before we conclude the session, I would like to summarize the excellent answer given by Guha sir. The thing I have asked for, that any cardiomyopathy patient going into recurrent hypoglycemic or hypotensive you say the recurrent fall, and you have evaluated for the fall thoroughly. through all the tests available, to alter examination, till test, everything done, and you do not find any cause of the fall other than the documented hypotension or hypoglycemia, definitely the first drug to be started is SGLT. You do not start ARNI in those cases. Hold ARNI for a week or two, start with SGLT. That answers all the pathological parameter for the diabetic cardiomyopathy is answered by the SGLT only. The time will come, we will have explanation for all the causes of the diabetic cardiomyopathy will answered by SGLT only, and start with SGLT and then build on the ARNI and then build the beta blocker and other things. Thank you very much.
Thank you so much. So, we wind up the first session. I will request the chairpersons to please stay on the dais and honor our first speaker, Dr. Sumit Shankar. A big hand for our speaker, Dr. Sumit Shankar, the opening batsman for the day. He did a wonderful job. And our second speaker, Dr. Shaibal Goa. Dr. Smith, please stay here. Thank you so much. Now I request our speakers to please stay here, sir. And I request our speakers to honor the chairperson. Chairperson, sir, you have done a commendable job chairing the first session. So first we'll honor Dr. Subhash. He's come all the way from Patna, our dynamic secretary of RSSDI BIHAR. Thank you so much, our chairperson, Dr. Subhash Kumar, our first chairperson. And Dr. P.B. Mishra, sir, please on. And Dr. Virender Kumar, sir. So one cardiologist of the town honoring another senior cardiologist and Dr. Shahwaz. Thank you so much. So thank you so much. Continuing with the second session, may I request the chairpersons, Dr. B.K. Singh sir, chairman of RSSDI BIHAR, sir. B.K. Singh sir, Dr. Raj Kamal Chaudhary sir, and Dr. Hemshankar Sharma sir to please come on the dais, and they will invite the speakers for the second session.
Hello. Good morning. This is the second session that we are starting. And I am thankful to the speaker, Dr. Ravi Kumar Modi, who is here to deliver his talk despite his very hard family problems. He just lost his father days ago, and today is the Dashkaram and all that. And despite that, he is here. So please extend a very big thanks to him. And just clap for him that the guts he has and the dedication to the RSSDI, what he is showing is unparalleled. That he is just to return back to Pune to do all these things. Ravi, the French chair of this medical college, of which all the three are here. We all four of us, I don't know how this has happened, that the three of us who are sitting here as chairpersons and the speaker, we are all the alumni of this medical college. We are all the alumni of this medical college. We are sitting in our own hall, and from the dais and from the benches to the dais, we have travelled many years to be here. Ravi is presently Vice Chairman of the API BIHAR 22-23, and Vice President CCDSI BIHAR Jharkhand Chapter 21-22, Postgraduate from University of Rajasthan in General Medicine, Graduate Diploma in Diabetes Care, Academic Counselor in IGNO, past Scientific Chairman of the BAPICON and CCDSI Con BIHAR, Director Modi's Diabetes Research Center. He is a very well known man, like the other friends from Patna, like Sehwal and all others. Subhash is there. We are all going to the right path of the RSSDI, expanding the horizons of the RSSDI in Bihar with the help of our friends, and particularly Dr. B.K. Singh specifically, I will say. So just anything, ask Ravi to just.
Thank you, sir, for your kind words. At the outset, I must pay my regard to the organizer of RSSDI BIHAR chapter, who has given me this opportunity to speak my presentation, and at the same time, what feeling I am having that this is my college. These are my teachers, Dr. Pandey. Those are my seniors. And what I am there, and I have learned ABC of medical science from here only, from them only. I sincerely pay my regards. So, respected chairperson, starting my presentation, management of diabetic food in physician's office. I am not going details of definition of diabetes, but diabetes is a chronic metabolic disorder affecting nerves, so neuropathy, eyes, kidney, blood vessels, so vasculopathy. So diabetic foot is the result of either neuropathy, vasculopathy, or its combination. I have forgotten the word ignoropathy. In fact, diabetic foot is the result of neuropathy, vasculopathy, and ignoropathy. In India, 75 to 90% of major foot problems in diabetes is due to neuropathy. Diabetic foot has become a matter of concern because it is a major cause of morbidity, mortality with great economic burden. Let us see the magnitude of the problem. In fact, inadequate management of diabetic foot disease can end in a very tragic end, that is amputation of a limb. It is the commonest cause of non-traumatic amputation, about 70%, and in every 30 seconds, one limb is amputated somewhere in the world. ADA has estimated that 50% of the limb with a foot ulcer can be saved if both healthcare provider and patients fulfill their respective responsibilities. So we have come here to fulfill our responsibilities. Spectrum of complication includes superficial cellulitis to chronic osteomyelitis and gangrene necessitating the lower limb amputation. Let us see the prevalence and risk factor. Globally, the prevalence is about 1.5 to 16.6%, and in India, it is about 11.6. The important risk factors are smoking, diabetic peripheral neuropathy, with loss of protective sensation, peripheral artery disease, foot deformity, callus or corn, bunions, hammer toes, Charcot joint. If there is history of diabetic foot ulcer or history of amputation, that is another risk factor. Poor glycemic control, presence of retinopathy, nephropathy, visual impairment, all are important risk factors for developing foot disease. And of course, in India, barefoot walking is a tradition that is again very, very common risk factors for diabetic foot disease. Human foot is a great mechanical marvel. It has got 26 bones, 29 joints, and 42 ligaments. It has got a very sensitive and protective skin blanket, excellent nerve supply, great vascularity with rich collaterals. So, why do have diabetic foot disease? And why not we have a diabetic hand disease? Before I answer this question, I will ask one question from you all. Man is the son of man, is the son of chimpanzee. Am I right or wrong? In fact, man is the son of chimpanzee. So in process of evolution, when we got a bipedal erect posture that has been acquired from a tetrapod posture, the weight bearing also confined to the two limbs only. So this is one of the reasons, and the other reason is that the distance from eyes to the leg is maximum, so probably the lower limb or foot is most ignored part of the body. So let us see the spectrum of the foot disease: subjective complaints, objective signs, dry skin, dermatophytosis, blister, bulla, callosity corn, foot deformities, diabetic foot ulcer, and Charcot foot. All comes in the spectrum of this foot disease. So how does diabetes affect foot? There is involvement of small fiber, there is small fiber neuropathy, so it is characterized by lack of pain sensation and paresthesia. There is large fiber neuropathy as well, that is characterized by loss of protective sensation in the form of distal sensory motor polyneuropathies. Motor involvement involves, and it is characterized by weakness and wasting of the muscles, crowding of the toes, pop of toes, hallux valgus, clawing of the toes, and it causes structural changes. Autonomic dysfunction is characterized by dry feet with reduced blood supply, increased bone resorption. Of course, vasculopathy is important, and peripheral artery disease may be there with reduced blood supply resulting in ischemia. So this is a slide showing all the complex interplay between atherosclerosis and polyneuropathy. All together, they will give rise to neuropathic foot disease, vasculopathic foot disease, or a mixture of neuroischemic foot disease or foot ulcer. ADA 2023, this is the position statement they have written. Up to 50% of diabetic peripheral neuropathy may be asymptomatic. And if not recognized early and preventive measures not taken, then the risk of injuries, ulcers and amputation get increased. There is no specific treatment for reversal of underlying diabetic peripheral neuropathy or neuronal loss. Only good metabolic control, control of glucose, control of blood pressure, control of lipids can prevent and retard the progression. So why diabetic foot needs special attention? It is because of poor wound healing, and the pathways are same that Dr. Sumit has described earlier in the first lecture. But additionally, there is peripheral neuropathy. That is one of the factors leading to the poor wound healing. Other is poor neuroinflammatory response due to involvement of autonomic dysfunction. Wound hypoxia is another additional factor resulting in poor wound healing. So how an ulcer develops? We can just compare it with a patient who is suffering or living with diabetes or with the non-diabetic subjects. We see repeated friction or stress. They can cause inflammation, pain, and that is the characteristic in a non-diabetic subjects. So this inflammation and pain, it goes to brain, and brain center respond it by changing the gait. And due to the change of gait, the healing process begins and there is repair of the tissue. But let us see what happens. What happens in a diabetic subjects? Repetitive stress or friction causes inflammation, but there is no pain. Quite surprised, there is no pain. So no response from brain, and there is continuous use of the limb, and there is no healing, and the result is a foot ulcer. So we have a campaign in RSSDI, Save the Fit campaign, and I have collected few photographs from them only, and these are the example of the repetitive stress. Result of repetitive stress or friction in namaz posture and in palsy posture. We can see the callosities develop over the bony prominence. We can see the friction caused by a shoe. Here there is right lateral bursitis. There is again a diabetic foot with wasting of intrinsic muscle. What I want to say that these all things can be prevented, and if we examine, if we recognize the pathological event happening in the diabetic foot, we can prevent them. Simple means of prevention, if someone praying a namaz and acquiring a kneel down posture, if he place a soft mattress there, soft pillow there, or someone sitting for yoga, pranayam with palsy posture, if they use a soft pillow under the foot, so these can be prevented. Now, this is again a diabetic foot showing fungal infection, wasting of muscles and clawing of toes. Here we can see there is complete destruction of the distal phalanges. This lady had an ulcer in the plantar ulcer in the right great toe, under right great toe, and there was dressing was done in locally. But when she came to me, we did a X-ray done, and there was complete destruction of the distal phalanges. So this is another example of Charcot foot. Few words about Charcot foot. See, in normal foot, we have a longitudinal arch which is concave, But see there in Charcot foot, it becomes convex, and the result is abnormal posture, abnormal shape of the foot, and it causes abnormal weight bearing due to the bone, and results in an ulcer. So altered biomechanics in diabetic foot. And a very famous saying by Paul Brand that the whole problem of neuropathic fit is really one of the mechanics, not of medicine. So, few words about diabetic foot ulcer. 15% will develop an ulcer in their lifetime, and commonest site is forefoot. There are few tragic rules of amputation and diabetic foot ulcer, that 85% of diabetic foot ulcer will be caused by amputation in diabetic patient. 85% will caused by a diabetic foot ulcer. 50% of amputation may be transfemoral or transtibial. 50% of patient will have a second amputation in less than 5 years, and 50% of the patient will die in less than 5 years. There is another rule of 15, that 15% of diabetes will have a diabetic foot ulcer in their lifetime. 15% of foot ulcer will convert into osteomyelitis, and 15% of foot ulcer will end in tragic amputation. So, how to examine? Inspection, palpation, footwear examination is very important. Neuropathy detection can be done by using 10 gram nylon monofilament and 128 Hz tuning fork. Of course, biosynchrometry is there, a small instrument that can detect the neuropathy. We can detect vasculopathy by simple palpation of peripheral pulse to sympathetic artery and posterior tibial artery. Of course, ankle brachial index can be measured, and we need a vascular doctor for that. So how to detect neuropathy? So we have to detect small fiber function, and this can be detected by simple pinprick and temperature sensation. We have to detect large fiber function, and this we can detect by lower extremity reflexes, ankle jerks, vibration perception, and 10 gram monofilament. Protective sensation can be discovered by using 10 gram monofilament. So what you need is your will, your desire, your commitment to detect neuropathy. and you need 2 minutes only. Because I know this pin, cotton, a tuning fork, and 10-gram monofilament, every clinic has. So you need 2 minutes to examine them, get neuropathy, detect early, and then manage it. So there is risk stratification also. So IWGDF has stratified grade 0, 1, 2, 3. Wegener's classification is there to classify ulcer 0, 1, 2, 3, 4, 5. Stage 2 to 5 needs surgical intervention. So these patients should be referred early. Examination of foot, we can see dry skin cracks, palpation, we see the peripheral pulse, mobility of great toe, and footwear examination, discouraged chapel and white chapel, impression on the insole and wearing out of the outsole points toward high pressure area of foot, a rigid outsole, a soft insole, roomy toe box, wide mouth, extra depth of shoe with a counter are the features of good diabetic footwear that is there. So these are few preventive footwears, few practical tips that male should be not cut like this, it should be cut straight. These are the points of the high pressure zones, and we should never walk or we should advise them not to walk barefoot. So coming to the management part, it is a teamwork, multidisciplinary approach is required. Physician, diabetologist has a key role to play. Other members of the team are surgeon, nutritionist, diabetic nurse, foot care worker, diabetic educator, diabetic cobbler. All are important for salvaging of a diabetic foot. Proper workup of diabetic patient is essential to establish neuropathy, vasculopathy or both. Tight metabolic control is very important, very essential. Principles of management are 4. Good metabolic control, appropriate use of antibiotics, extensive debridement and offloading. These are the 4 pillars for the treatment of the diabetic foot. Purpose of metabolic control is prevention of hyperglycemia, prevention of ketoacidosis, hyperosmolar coma, dehydration and sepsis, and promotion of normoglycemia, control of infection, fast healing and attainment of normal productive life. This may be achieved by prompt diagnosis, timely intensification of diabetes control by insulin, especially short acting, frequent monitoring, and we should know the target blood sugar 140 to 180 milligram in hospital setting, and in perioperative period 80 to 180 milligram. Route of administration may be subcutaneous or may be infusion as per need. OAD or oral drugs are not preferable in period of stress. So we must classify the wound whether it is non-limb threatening, limb threatening and life threatening. So limbs which are limb threatening and life threatening should be referred, should be admitted with the help of surgeon. Of course, physician has important role and he must stabilize the patient, must control the blood sugar, must control the blood pressure and all other metabolic derangements. Minor problem becomes major and life-threatening if diabetes, if not care taken early. So in cases of diabetic foot disease, non-limb threatening in conditions can become limb threatening and finally life-threatening. So we should be very careful in that. Non-limb threatening conditions like callosity and cord, dermatophytosis of west space, deformity like hallux valgus, hamartose, fissure and cracks, hypertrophic vasculitis can be managed in outpatient basis by giving proper advice regarding the foot care and footwear. Minor OPD procedures for callus and cord removal can be done. Appropriate use of antifungal drug for dermatophytosis, moisturizing lotion of cracks and fissures, and advice, sir, I need almost 10 minutes. 3 minutes. So, if mild infection is present, then empirical antibiotic use can be done. Moxifloxacin, cafetinib, linezolid, cephalexin, and azithromycin are another important that can be used. Limb-threatening and life-threatening diabetic foot conditions needs indoor admission and help of surgeon for proper management. So identification of such condition is important for early referral, but before sending to a surgeon, a physician must talk to the surgeon and discuss the modality of management regarding correction of dehydration by appropriate intravenous fluid, insulin infusion, for correction of hyperglycemia, selection of empirical antibiotic in consideration to the renal states before the result of culture sensitivity comes. In limb-threatening conditions, preferred intravenous antibiotics are cefpoarazone sulbactam with metronidazole, moxifloxacin with metronidazole. For life-threatening condition, piperacillin tazobactam combination with amikacin, meropenem and clindamycin plus amikacin. But the final antibiotic choice depends on the result of the culture sensitivity. This is for just empirical guide to use antibiotics in those conditions. A physician must discuss with the surgeon that the best dressing material for diabetic foot is normal saline. Use of Savlon, betadine, hydrogen peroxide, eosol is not suitable for diabetic wound because they have direct cytotoxic effects to fibroblast and keratinocyte. Use of topical antibiotic is good for keeping the wound moist because moist environment is ideal for healing of a diabetic wound. There are multiple ointments for this purpose. Always remember the final choice of antibiotic depends on the results of culture sensitivity. Clindamycin, azithromycin and moxifloxacin can safely used for patient with impaired renal function, but for the rest mentioned antibiotics, dose adjustment is very important. So these are few offloading devices. This is ortho wedge is there, total contact cast for Charcot foot is there, pro boot, removable boot, post of shoes or offloading devices. This is the anterior 4-foot wedge for ulcer which is situated in the hind foot, and the lower is the posterior wedge for ulcer situated in the anterior part. This is a rocker bottom for redistribution of the plantar pressure. So we can hand over such type of leaflet to the patient just to aware them. You have to see your feet daily, you have to inspect, and we can give such type of leaflet to the patient. And to conclude lastly, prevention is the first and last weapon for the management of diabetic foot. A new diabetic patient with his first interaction with a physician or a diabetologist is being instructed about foot care, which is a preventive strategy. And even a serious complication occurs and ends in amputation of limb, very tragic. He is again instructed to take care of the unaffected remaining limb and the care of the stump. So much feet of a diabetic patient, he will give you blessing. Please give it 2 minutes to your diabetic patient. The journey begins with prevention and ends with prevention. So thank you very much for your patience.
Thank you, Ravi. It was indeed a very good presentation, and we did not care with much about the diabetic limb. So with your talk, I think it has opened our eyes, and mostly the people, we must educate the people with who are coming with diabetes in the ranges of 600 or above, that there are chances of having diabetic foot, and if they are uncontrolled diabetic levels. So that was indeed a very good talk, and thank you for it.
Excellent presentation, Dr. Akamudi, as usual. One thing is that Dr. Anil Maheswari is here, and we had a program of Save the Feet by the RSSDI, and UP chapter of RSSDI did a very commendable job during the Save the Feet program. So it is very important part that we must see your leg or the foot first, then to see your face. That is the clear message of to prevent the complications of diabetic foot. Excellent. I know that you have to lead this. So may I request organizer to give moment to the Arkin motive for Dr. Manish, please.
May I request for chairpersons to please honor Dr. R.K. Modi sir as he has to leave early. Many thanks sir that we could make into this meeting despite personal bereavement. Yeah. Thank you so much sir. I'll continue with the second talk of this second session.
Now I invite after Dr. R.K. Modi, a very young and dynamic diabetologist of Chhattisgarh, Dr. Arun Kedia. He is the one person who has done tremendous work for RSSDI, for diabetes, for rheumatology in Chhattisgarh. And he has come a long way from this Raipur to here to deliver a talk. And the topic is the GDM, a window of opportunity of the future non-communicable disease. You all know that the conversion rate from the GDM to the apparent diabetes is nearly 14% in India. That is a very huge. So we can prevent the future diabetics, and how we can prevent it, we can listen to the Dr. Arun Kedia. Please, Arun.
My previous speaker felt honored to be at his alma mater, and I am privileged to be in Bihar for the first time. And for that, I thank the organizers to have me here in this beautiful part of the country. I had my learning in a residential school, and I had a lot of friends from Bihar, Sharif, Nalanda area, and I longed a lot of time back to come to Bihar, and my dream came true. So today I am here in front of you all in this August gathering to express my views on gestational diabetes, which is a window of opportunity for future NC. So as the epidemic of diabetes as well as obesity is increasing, we do have some evidences now that the future of prevention of diabetes as well as obesity lies in prevention of GDM and managing GDM more strictly. So with that note, I will begin my lecture with the classification of hyperglycemia in pregnancy. So you can have a pre-existing diabetes who develops pregnancy, or you could have a pregnancy which first presents in a case of hyperglycemia which first presents in pregnancy, and that is what is the gestational diabetes. Now in this you can have an early gestational diabetes where the patient probably had a pre-existing diabetes and is diagnosed in the first trimester. But what is classical gestational diabetes is the one which is diagnosed in the second or third trimester, and that is what we have conventionally learned as gestational diabetes. So coming to the definition, if you see the conventional definition, it is any degree of glucose intolerance with onset or first recognition during pregnancy, regardless of the gestational week. But if you see the current ADA classification of 2021, women diagnosed with diabetes in the first trimester is classified as pre-gestational diabetes, whereas diabetes diagnosed in the second or third trimester that is not pre-existing diabetes is called as gestational diabetes. Whereas the DIPSI, that is our Indian guidelines of 2021, states that GDM is any degree of glucose intolerance with onset of first recognition during pregnancy. So what we conventionally learned about 28 to 32 weeks is now we are trying to detect this glucose intolerance at a much earlier stage, probably even preconceptionally. So coming to the statistics of the epidemiology of hyperglycemia in pregnancy, if you see this bar diagram, it shows the prevalence as per the IDF 2017 Atlas. And what you can see is the Southeast Asian countries, you can see that the prevalence is almost to the tune of 26%, which is quite high. And if you see the overall prevalence globally, they say that 1 in 6 live births today occur to women with some or the other forms of hyperglycemia. So this problem and this magnitude of the problem is very, very high. And more so ever, if you see the Indian data, in India alone, GDM complicates nearly 4 million pregnancies annually. Now this number may seem to be much smaller to the physicians, or maybe too large for the physicians, because not all GDM are referred to the physicians. Many GDMs are actually undiagnosed, or they are casually managed by the gynecologist. So we don't actually see these large numbers in our day-to-day practice. So a word about pathophysiology of GDM. So GDM represents basically a stage of chronic beta cell dysfunction, and it is one of the stages of the evolution of type 2 diabetes. And this is the concept that actually percolates into our prevention of GDM to prevent future diabetes and future non-communicable disease. So if you see the non-pregnant woman, there is a balance between insulin secretion and insulin resistance, and the blood glucose remains normal. But what happens in a normal pregnancy? In a normal pregnancy, you have some insulin resistance, which is physiological, in order to provide nutrition to the fetus, and this is probably because of some of the cytokines, some of the hormones. But overall what happens is a normal woman compensates for that insulin resistance with increased insulin secretion, and so the woman remains euglycemic and does not develop GDM. Now what happens in GDM? You have insulin resistance and there is an underlying beta cell dysfunction, which now gets masked and it gets manifested. So the insulin secretion is not able to match the insulin resistance, and this woman develops GDM. So if you see the overall glucose intolerance in GDM, it is the result of the woman's inability to increase insulin secretion in order to overcome the insulin resistance that occurs even in a non-diabetic pregnancy. And this is very important to understand, that we need to diagnose this inability to increase insulin secretion in a woman in order to prevent future risk. So why do we need to diagnose GDM? So if you ask me what is GDM, there are two questions. Is it a medical complication of pregnancy, or is it a pre-existing condition? So if you see the older textbooks, they write that GDM is one of the most common medical complications of pregnancy. Whereas I differ, I would say that it is a pre-existing condition which actually gets manifest in pregnancy. So GDM is actually a chronic cardiometabolic disorder that identifies women who have an elevated lifetime risk of ultimately developing type 2 diabetes and cardiovascular disease. So it is not a medical complication of pregnancy only. It is a pre-existing condition. And moreover, nowadays we have evidences that it also holds very important in order to prevent future cardiovascular or diabetic risk even in the next generation. And this diagnosis raises the possibility of our early intervention and risk modification in the women. So GDM actually impacts two lives. It is not only the woman but also the fetus. So the diagnosis of GDM identifies women who are at high risk of future diabetes and associated metabolic problems. At the same time, maternal hyperglycemia is associated with the similar problems or the metabolic problems even in the developing fetus, and which would lead to future cardiovascular risk in the child. So hyperglycemia during pregnancy, apart from causing increased mortality and morbidity in the woman and the infant, it also leads to future risk. So this lies wherein the opportunity to prevent the future non-communicable diseases and the metabolic disorders. So that is why this GDM is considered to be a window of opportunity. So if you see the lifetime risk of type 2 diabetes, as Dr. B.K. Singh sir said, that they convert to diabetes at a very fast rate. If you see this data from ADA, again you can see that the absolute risk increases linearly through a woman's lifetime. So at 10 years, 20% of these GDM would be having diabetes, and by the end of 50 years, 60% of these women develop diabetes. So this was an article published in Lancet 2009, and what you can see in this particular graph, you can see that the risk increases linearly with the age of follow-up. So on the topmost chart, if you can see, this is for GDM with overweight and this is GDM with normal weight. You can see that with overweight, the graph increases still more sharply. Whereas if you see this control, the women with normal weight or the control with overweight, you can see the conversion rate to GDM is much lesser compared to the conversion to diabetes with GDM diagnosis. Apart from GDM, the other risk factors that I said was obesity, and you can see that there are two more parameters that we need to understand in women. One is the obesity and the other is the pregnancy weight retention. So we know that during pregnancy, whatever weight is gained, some of the women, they retain the weight. So if you see this non-GDM, non-pregnancy weight retention and a lean woman, if you see the risk of developing diabetes future as 0, you can see that in GDM with weight retention and with obesity, you can see the risk at 10 years is almost 10 times. So this is the importance that apart from GDM, we need to also check for the weight gain that the women have during pregnancy and the baseline body structure or the body habitus that these women have. So if a woman is diabetic during pregnancy and she is obese and she also has now a pregnancy weight retention, then these women are much more at risk of future diabetes. Apart from future diabetes, these women are also at a very high risk of cardiovascular diseases. And this study published in 2009, it says women with a history of GDM have a higher prevalence of metabolic syndrome and increased risk of cardiovascular disease. Similarly, the another study, they say over 10 years, women with GDM had more non-invasive cardiac diagnostic procedures. So this indicates that these women present with either non-stimulation MI or they come with atypical chest pain and they undergo a lot of cardiovascular hospitalizations after adjusting for the age, ethnicity and other comorbidities. So there is a future cardiovascular risk to the woman, there is a heightened risk and overall there is a twofold high risk of future cardiovascular events. Moreover, this risk occurs early in the life course of a woman and there is 2.3-fold increased risk in the first decade postpartum. So the women develop early coronary artery disease or early cardiovascular diseases if they have the history of GDM, and that is the reason why we need to diagnose GDM in every pregnancy wherever possible. We also talked about the weight gain, and this is the reason where the gestational weight gain also needs to be taken into account. So if you have the first pregnancy which led to some weight gain, and if this weight gain is retained, later in life these women become obese, and once these women become obese, if they have the history of diabetes in the first pregnancy, they are likely to have increased risk of type 2 diabetes, increased risk of cardiovascular disease and increased risk of metabolic syndrome. So during pregnancy, whatever weight gain the women has had, it is necessary that we need to bring down this weight again in order to reduce the future risk of cardiovascular disease. So the risk of non-communicable disease during the life course of GDM does not affect only the woman, it also affects the fetus. And what you can see from this graph, if you have a woman with first GDM pregnancy, that during the second GDM you can see the trajectory of risk going steeply up, and there is a high risk trajectory for most of these women. But if you control these women with a healthy diet, with a healthy lifestyle, with a good preconception counseling, you can see that the risk to the fetus is low. But if you're not taken control of all these measures, you can see that the corresponding NCD risk in the offspring also increases. Now offspring, the early stages of offspring have a plasticity phase. So it's like, we say कि अभी तो मिट्टी का है, आप जैसा ढालोगे वैसा ढल जाएगा. So this is the phase of this child. If you don't take care at this moment, then there will be an increased risk of future NCD. And this is what is the life course of future NCD even in the offspring. So from the mother, we move on to the risk of the offspring. And for that, I'll bring into picture this particular scientist, the David Barker. I know most of you must have heard the Barker's hypothesis. He conceptualized that the body's susceptibility to lifestyle disease is programmed intrauterine. and this is very important to understand. So I would be coming up with 3 hypotheses that you need to understand: the Barker's hypothesis, the Frenkel's hypothesis, and the Peterson's hypothesis. So I'll go one by one into that. So coming to the first hypothesis, that is Barker's hypothesis, it states that the susceptibility to cardiovascular disease or all future NCDs is programmed in utero. And what it means is the exposure during a critical period in development may influence later the metabolic or physiological functions in the adult life. And that is the reason why adverse environment in the fetal life or early childhood lead to increased risk of disease in the adult life, and that is where the prevention lies. So this is in a nutshell about the Barker's hypothesis. So you have genes which decide your phenotype. At the same time, what he says that apart from the epigenetics and postnatal environment, you have the intrauterine environment which also decides your phenotype. And this intrauterine programming, that is called as the gestational programming, it says that it permanently changes the structure, physiology and metabolism. So it is not a transient phenomenon. So once you are exposed to an adverse intrauterine condition, there is a likelihood that you have a permanent damage to your genes, and that will predispose individuals to diseases in the adult life. So that is what is called as the fetal origin of adult disease, which was proposed by David Barker. So the next theory that I would be talking about is the Frenkel theory. Now Frenkel says that maternal metabolism in pregnancy changes physiologically to provide an uninterrupted nutrient supply to the fetus, and that is why we have a physiological insulin resistance. So he says fetus is a continuously feeding boarder in an intermittently eating host, which is the mother. So what is his hypothesis is that there is an influence of maternal fuel during pregnancy. So what he says that there is something called as fuel mediated teratogenesis, and whatever the mother eats or whatever the metabolic products of mother is, it causes a long-term anatomical and physical functional changes in the fetus. So this is the diagram which shows the Frenkel hypothesis. So if you have a maternal GDM, you have abnormal transfer of carbohydrates, fat and amino acids to the fetus, which leads to increased insulin secretion, which tends to cause macrosomia to the fetus. So this is what we know in our from our MBBS days. But what happens is that this fetus is now programmed through these toxic products, and they lead to NCDs, which leads to obesity, metabolic syndrome and impaired glucose tolerance in the future life. So there are multiple nutritional factors along with glucose which lead to teratogenesis in the fetus. And then the third comes the Peterson hypothesis, which we learn in gynecology and obstetrics training, that when you have a glucose crossing placenta, the carbohydrate surplus to the fetus is increased, there is increased fetal hyperinsulinemia, which leads to macrosomia, organomegaly, polycythemia and respiratory distress syndrome of the infant. So that theory that the macrosomia is related to increased carbohydrate supply to the fetus is also known to us since 1950. So now if you combine this Frenkel as well as Peterson hypothesis, what you get is that in maternal GDM, if you have this increased glucose transfer through the placenta, there is macrosomia, but because of increased insulin secretion, these children get epigenetic regulations and they are tend to having obesity as well as future cardiovascular disease. So in the males, there is likelihood of increased impaired glucose tolerance, whereas in the future female offspring, there will be a GDM. And this GDM will manifest as diabetes in the future offspring when their child grows up. So what has happened is that this diabetes has led to another diabetes, and this woman, when she becomes pregnant, she will again become a pregnant diabetes, and this cycle will continue, what is called as a vicious cycle of diabetes begetting diabetes. So we must stop this, otherwise the cycle will not stop. So this is in a nutshell about all the three hypotheses put together. So if you have a maternal GDM, you have in utero overnutrition, you have epigenetic changes in the genes, you have altered physiology. This is permanent altered physiology which increase risk of obesity, diabetes and cardiovascular disease in the offspring, and that leads to intergenerational effects and long-term risk of future NCDs. So now I come with some of the evidences. So this is a very famous study, the HAPO study, which revealed the adverse pregnancy outcomes with GDM. And what we saw that the linear risk of adverse outcomes with GDM pregnancy, if not well managed,
But what I want to bring attention to you all is this study which was published in 2019. Unfortunately, this study did not gain importance because in 2019, soon after this study was published, the COVID came and the entire media busted with only COVID related studies, and we forgot to go into the depth of this study. So this is a HAPO follow-up study. So what they did was, the infants which were born to the mothers during the HAPO study, they were followed up for 10 to 14 years. So now these children who grew up and they were 10 to 14 years old, they were studied for the cardiovascular risk and the diabetes. So what the conclusion of this study was, that the offspring exposed to untreated GDM during that time, in 2006, in utero are insulin resistance with limited beta cell compensation compared with offspring of mothers without GDM. So this is very, very important that this study came out with. So the objective of the study was basically to see whether hyperglycemia in utero less than overt diabetes was associated with altered childhood glucose metabolism. So the follow-up study was done with 4,160 children, and the child outcome that was studied was impaired fasting glucose, impaired glucose tolerance, and type 2 diabetes in the children. And what they found was that GDM was associated not only with the child's 2 hours glucose but also 30 minutes and 1 hour postprandial glucose. Also, there was no relation to fasting plasma glucose. So this further put us the theory that probably the liver, the sensitivity at the level of liver is not affected by GDM, but definitely the sensitivity at the level of skeletal muscles is affected in GDM, and that is what is the future research that needs to be done. Similarly, the HAPO follow-up study, the second part they studied, they found that there is a continuous relationship between maternal glucose levels during pregnancy and childhood adiposity outcome, and this was independent of the maternal BMI. So again, there was a linear relationship between maternal hyperglycemia and childhood obesity. Then the third study that they did was newborn adiposity and cord blood C-peptide as mediators of maternal metabolic environment in childhood adiposity. And what they found was newborn adiposity was independently associated with childhood adiposity, and along with fetal hyperinsulinemia, it mediated association of maternal glucose and BMI with childhood adiposity. So this is the chart which shows that you can see that maternal glucose tolerance and maternal adiposity, if you see both the confounders, the contribution of maternal glucose intolerance was 15% as against only 3% contribution of maternal adiposity. So obesity in mother does not contribute so much to childhood obesity as maternal impaired glucose intolerance contributes. So this is another very important outcome that these studies came up, and I would request all of you to go through these studies, excellent studies and excellent outcomes that they have printed. Then this was a recent publication in via March 2022 where they showed that gestational diabetes is also associated with the cardiovascular disease in children through epigenetic changes, through nitric oxide metabolism, and through germline mutations. So coming to the management of GDM, the goal should be not only to improve the perinatal, sir, last 2 slides, sir. Okay. Not only to improve the perinatal outcome but also to prevent long-term maternal and fetal effects, and the St. Vincent Declaration said that you must achieve a pregnancy outcome in a diabetic woman which would approximate to that of a non-diabetic woman, then only probably we can prevent the future cardiovascular disease. So what is the importance of early diagnosis of GDM? We need to screen every pregnant woman. We have seen the consequences of GDM and the benefits of testing as from the HAPO study. We must test at every first booking and subsequently at 24 to 28 weeks if the first test is negative, and we must adopt the DIPSI method of one-step 75 glucose tolerance test. But what is most important, once you have diagnosed and treated this GDM and once this woman has delivered, you need to follow up this woman with a follow-up screening, and unfortunately the postpartum glucose testing is very, very poor because most of the women, they are now busy nurturing for the females. We don't have gynecologists enough to take care of the postpartum screening and postpartum management because the gynecologists are not very much keen and interested in doing this postpartum testing. So our approach from traditional to futuristic approach should be that we must screen the women early, we must treat them early, and we must screen them and postpartum follow up them to prevent the long-term maternal and offspring outcomes. So pregnancy, definitely GDM offers a window of opportunity, to reduce the traditional morbidity and mortality and to address the intergenerational prevention of all future non-communicable disease. So the early diagnosis is the need of the hour, and as our Professor V. Shayas has said, the diabetes-free generation can be only achieved if we focus on the fetus for the future. And as we can see, the theme here is the education to protect tomorrow. So probably the theme in the coming time should be to focus on the women to protect the future generation from cardiovascular disease and non-communicable disease. With that, I thank you all, and I apologize to take a few minutes extra.
Thank you, Dr. Arvind. It was indeed a nice presentation. Well, there is one question which haunts me. That is why this TDM occurs only in selective patients, because you very well know that all patients of pregnancy do not carry on with the JDM. So what is the basic factor, the basic reason of its involvement, predisposition?
So in one of the slides I have shown very clearly that GDM exists as a pre-existing cardiometabolic disorder. Unfortunately, prior to pregnancy, the woman compensates for the excess insulin resistance. But what happens once you get pregnant? Pregnancy itself is a stress test, and during this stress there is hyperglycemia, and in a pregnant non-GDM woman there is compensation with insulin secretion, but in a woman with an underlying beta cell dysfunction there is lack of compensation, and this lack of compensation is actually what is GDM. So GDM is a manifestation which is already existing in a woman in the form of chronic beta cell dysfunction, but it gets overt presentation during a pregnancy as a stress test.
Comment and question.
Sir.
Thank you. Not question, 2-3 very important things. You have done a wonderful job. There is no question arises out of this great presentation. You have covered each and everything wonderfully. Whatever I wanted to comment before that, I would like to have a comment on this question also. That pregnancy is the only condition in which the insulin resistance is the key. And insulin resistance is actually the key which is behind everything which is happening in pregnancy, including the development of the fetus and growth of the fetus. So this is the thing which is welcome in the pregnancy across the throughout life of the individual. Insulin resistance is welcome only in the pregnancy. So once this is welcome in the pregnancy, and with the increasing insulin resistance, it is ensuring the growth of the child as well as fetus, then definitely if it is being over there, then definitely it will lead to the other diseases which are associated with the insulin resistance, or what we call that metabolic syndrome. And sometimes we also call it that pregnancy is a small version of the metabolic syndrome, in which all those activities which we see in the metabolic syndrome in a patient, they happens in the pregnancy, but for a good cause, for a better cause, that is the growth of a child which is going to be developed inside the womb. Second thing is that your whole of the presentation is very good, but one thing I won't agree with that you said that gynecologists are not interested in the post pregnancy testing of the mother and baby. Actually, it is not. Factually, it happens that family members of that lady become so much reluctant after getting a childbirth, after getting a baby. They get so much reluctant, they forget that after 6 weeks they should come back and they should check their glucose level. So we should develop some such kind of the system in which we can do this testing, and so that we can know that which women is going to become type 2 diabetes after this pregnancy or not. And another important thing, if we shall control the glucose level up to the desired limit, what the DIPSI has told us, that less than 120 milligram per deciliter, probably the women will not convert into the type 2 diabetes. तो हमने बिहार में और उत्तर प्रदेश में आज से 10 साल पहले एक कैंपेन चलाया था, दैनिक जागरण वालों के साथ मिलकर, दैट वाज कॉल्ड एज जागरण पहल। तो उसका स्लोगन दिया था, एक जांच से बचे दो जान। तो अगर हम प्रेगनेंसी में ब्लड ग्लूकोज टेस्ट करते हैं तो हम मदर को डायबिटीज होने से रोक सकते हैं और आने वाले बच्चे को डायबिटीज होने से रोक सकते हैं। और सबसे बड़ा कि जो फ्यूचर जनरेशन में जो आजकल हम देख रहे हैं, आजकल भी यंगस्टर्स डायबिटीज हो रहे हैं, जो 20 इयर्स में लोगों को डायबिटीज आ रही है, उसका एक बहुत बड़ा रीज़न ये है कि हम जेस्टेशनल डायबिटीज को कंट्रोल नहीं कर पा रहे, जिसकी वजह से चाइल्ड इज डेवलपिंग पुअर ग्रोथ चाइल्ड, एंड जैसे ही वो बाहर आता है फीटस से, ही स्टार्ट्स टेकिंग अ फूड, ही बिकम्स ओबीज एंड देन ही डेवलप्स डायबिटीज व्हेनेवर ही बिकम्स। तो इंसुलिन resistance related diabetes is increasing more among those who are developing the gestational diabetes in their home, and if we can control, we can reduce that.
Thank you. Thank you. It was a good comment. Anything, Anand? Oh, it is done already. So your questions have been just taken up and snatched by Dr. Anuj. Oh, sir, I'm very sorry. Sir,
With your permission, a question to the PGs.
Okay.
They have been listening. Please ask them what do they understand by the term primordial prevention. Any of the PGs can answer.
Any of the PG primordial?
Because that has been answered both by Dr. Arun Kedia and Dr. Anuj.
Yeah.
So they should understand what is the meaning of primordial.
That will be during lunch. Thank you. Thank you. Now the organizers, please.
John. Thank you so much, Dr. Arun, for a wonderful job. Please come on the stage, sir. I request chairpersons to honor Dr. Arun with
एक ओबीज आदमी को अगर डायबिटीज़ प्रिवेंट करने के लिए हम उसको कहते हैं कि आप वेट रिड्यूस कीजिए, तो दैट इज़ प्राइमरी प्रिवेंशन फॉर डायबिटीज़, ठीक है। और अगर हम डायबिटीज़ प्रिवेंट करने के लिए हम ओबेसिटी ही प्रिवेंट करते हैं, दैट इज़ अ रिस्क फैक्टर फॉर द डायबिटीज, दैट इज प्राइमरी।
Dr. Hemshankar Sharma. Dr. B.K. Singh sir. And Dr. Raj Kamal sir. Thank you, sir. Thank you so much. Going on to with the next session, may I request the chairpersons, Dr. Sudhir Chandra, Dr. Vilesh Kumar, and Dr. Rajeev Sinha to please come on the dais. Dr. Sudhir Chandra.
Manish, I am the speaker. I am the second speaker.
Chair
Chair Now to start this important session, we have got a stalwart, an icon, Dr. Anuj Maheshwari, who needs no introduction. And I will invite him to deliver a very important talk on non-alcoholic fatty liver. Dr. Anuj Maheshwari.
Thank you. Thank you, chairpersons, for the kind introduction, and thank you, organizing committee, especially Dr. B.K. Singh, who not only invited me to come here but also motivated that I must come here, and I am really very happy. In fact, in last few years I have visited Bihar so many times that it doesn't look that I am going somewhere out of my state. I always feel the same pleasure while speaking Bihar as I feel that in Lucknow or in Uttar Pradesh sometime. A very important topic today we are going to cover through this talk, that is a non-alcoholic fatty liver disease and diabetes. As we were discussing in the previous session, that there are certain diseases which are associated with insulin resistance, and they go on vis whenever we go with one disease related to the insulin resistance. Some other diseases which are also related to that, they come silently and they keep on growing silently in the same individual, and that happens with the NAFLD also. What is NAFLD? NAFLD is actually the fat deposition in the liver, and this is also initiated by the same insulin resistance which is initiating the diabetes. So whenever there is a diabetes, many a times we have our focus on the glucose level of the patient, but many a times we forget to have our focus on the liver of the patient, which is having silently the deposition of the fat in it, and many a times it is so much even at the development of the diabetes, even at the diagnosis of the diabetes, that if you get test of your patient's liver function test, you may find that at the first time whenever he is coming to you with the hyperglycemia, then he is also having the high level of the liver enzymes too. So when these two diseases are existing together, diabetes promotes the deposition of the fat in the liver. It also increases the risk involved with the cirrhosis and hepatocellular carcinoma. And both these risks are going side by side with the growing inflammation with the liver deposition of the fat in the liver. And they all are initiated with the insulin resistance. At the same time, the NAFLD also increases its contribution in the complications of the diabetes. It worsens the insulin resistance, increases the atherogenic dyslipidemia. That is the worst outcome of the insulin resistance, is actually responsible for the adverse cardiovascular outcome. A person who can get the heart attack in its early age if he is having so much high level of the insulin resistance, which is giving rise to that much of a deposition in the fat in liver, is leading to the atherogenic dyslipidemia, which is actually characterized with the high level of the triglyceride and at the low level of the HDL, which is very commonly seen in our individual. We can say that Indians are characterized by these two levels of the hypertriglyceridemia and low HDL, and which are the sign of this NAFLD and type 2 diabetic. So this increases the risk of the cardiovascular. what happens of this coexistence of type 2 diabetes and NAFLD together? A healthy liver, once a person starts developing the type 2 diabetes, in the process of developing in the rising insulin resistance, gradually he starts having deposition of the fat in the liver. And once this fat deposition is associated with the inflammation, the NAFLD gets converted into the NASH, that is called as non-alcoholic steatohepatitis. Till this level, the disease always remains reversible. But when it crosses this level and enters to the phase in which the cirrhosis and fibrosis starts occurring, then it becomes irreversible, and most of the time it ends with either hepatocellular carcinoma or death, or if the patient has the affordability and facility to get the liver transplantation, probably then in that case he can avoid the death. So if we wish to define the non-alcoholic fatty liver disease, as I said, that this is a deposition, sizable amount of the deposition of the fat in the liver, and it can only be diagnosed either by histology or by the imaging. So if we are going with the histology on imaging and there is a more than 5% of the hepatocytes are having studded with fat, or they are having the steatosis, this is actually called as non-alcoholic fatty liver disease. There is a more precise definition, if we can go with that, by proton density fat fraction or by MRI spectroscopy. If it is more than 5.6% of the fat in the hepatocyte, or we can say more than 5.6% hepatocytes are involved in the fat deposition, this is called non-alcoholic fatty liver disease. Apart from this insulin resistance, there are a lot of secondary causes of the steatosis, also a lot of secondary causes of the fat deposition, which should always be ruled out before labeling any patient with the NAFLD, like alcohol consumption. That's why the name is the non-alcoholic fatty liver disease. But even if the alcohol consumption is not one of the cause of the fat deposition, but there could be some other causes of the fat deposition, like viral hepatitis, like steatotic medication like imidazole for long-term methotrexate use, amoxicillin, hemochromatosis, autoimmune hepatitis, celiac disease, Wilson's disease, lipoproteinemia, lipoatrophy, and sometimes microvascular steatosis can also occur in the Rees disease. Medications like valproate, ARTs, acute fatty liver in the pregnancy, HELLP syndrome, and many inborn errors in the metabolism are also associated with the deposition of the microvascular steatosis. Asian Indians have low insulin sensitivity compared to the Caucasian counterpart. It is well known fact. In India, the prevalence of the insulin resistance is 35% even in the young age. So the deposition of the fat starts with the young age. Many times we always remain in this confusion that diabetes is starting on the day when we are first diagnosed with the hyperglycemia. Actually, we are wrong. Diabetes is starting on a day 15 years before when we are diagnosing and we are getting our hyperglycemia for the first time. 15 years before the endothelial dysfunction process starts taking place, and after that we start having the rising insulin resistance that goes up with our physical inactivity, and obviously the dietary habits also have some say over that, but it increases gradually with the deposition of the fat, and that is the reason after generations and generations the occurrence of the diabetes is going back in the age. Earlier it was in the 60 years above, later it has been on the 40 years above, now we can see that type 2 diabetes in the 20 years and above. So insulin resistance is one of the root cause factors, and if we need to diagnose the 5% steatosis in hepatocytes should be confirmed by the biopsy or imaging methods. Insulin resistance should be confirmed, and there should not be any secondary causes, what I have already enumerated in my previous slide, and alcohol consumption should not be more than 30 grams in a day for men and 20 grams in a day for women. If it is like that, then we can say that probably this is the patient of the NAFLD. So if we talk about its prevalence, it is a growing public health problem reaching to the epidemic proportion and is considered as the most common cause of the chronic liver disease nowadays. And in future, we shall be seeing a lot of cases of the chronic liver disease which are arising out of this NAFLD caused by the insulin resistance, which may be involved with the diabetes, obesity, diabetes together. The prevalence of the NAFLD is 31% by MR spectroscopy, 12.2% by histology, of which 5% are associated with the inflammation that is called that non-alcoholic steatohepatitis. The prevalence of the NAFLD in diabetic individual is 59.67%, means almost 60% diabetic patients are developing the NAFLD. And it has been seen that biopsy-proven NASH in asymptomatic type 2 diabetes patient is going to this level, and we can see that even 20% of them are having normal liver function test. So actually the liver function test or liver enzymes are not the true reflector of the NAFLD. 20% of them keeps on normal. So if we talk about the comorbidities with the NAFLD, so obviously the metabolic conditions are giving rise to that, which includes, as I already said, type 2 diabetes, obesity, dyslipidemia, and of course hypertension. Hypertension is also one of the important diseases which is associated with the high insulin resistance. So whenever we are coming across with the hypertension 140/90 or more than that, this may be one of the important factors which is giving rise to the fat deposition in the liver. But the most important thing which is causing NAFLD in our youngsters, that is the physical inactivity. Physical inactivity, high calorie diet, sweetened beverage, high fructose intake, and obstructive sleep apnea, which is growing with the weight gain and obesity. Obviously, the reflection of the same high insulin resistance we can see in our young girls in the form of the polycystic ovarian syndrome. So overall prevalence NAFLD in India up to 32%, NAFLD in obesity is almost 80%, and type 2 diabetes 70 to 80%, and 50% are progressed to advanced fibrosis. So this is the scenario of the pathophysiology will start. As I already said that we are starting the diabetes on the day when we know that hyperglycemia has first detected. But even 10 years or 15 years before the process of that hyperglycemia and pathophysiology start taking, which from with the endothelial dysfunction, and at the same time we start getting the rising of the insulin resistance, which starts developing the fat deposition even in the lead state of the diabetes when a person is in the non-hyperglycemic state. And when it comes to the hyperglycemic state and beta cell dysfunction is going rising up to the highest level, where you can see that insulin resistance at the highest of its level, but the insulin secretion at the lowest of its level, and we can see the highest amount of the fat deposition there. Let's talk about the pathophysiology. कैसे होता है, कहाँ से आता है, ये सब चीजें क्यों डेवलप होती है? If we talk about the fat which is coming to the liver, is coming from the three important sources. हम लोगों में से बहुत सारे लोग ऐसा सोचते हैं कि ये जो हम खाना खा रहे हैं फैट उसमें से आ रहा है, but actually it is not the food derived that much. It is contributing up to certain extent, but the maximum is coming through the free fatty acids which is in the circulation. And free fatty acids which is in the circulation, it is coming because of the insulin resistance. So it is coming, insulin resistance is coming because of our physical inactivity. So if we increase our physical inactivity, we can stop this or reduce the amount of this free fatty acid which is coming. I can tell you it's around 56% of the total fat which is going to be deposited in the liver is contributed by the free fatty acid. And 26% is contributed by the de novo lipogenesis. What is the de novo lipogenesis? De novo lipogenesis is that what we take in the form of the carbohydrate, but we do not spend. We take a lot of energy in the form of the carbohydrate, but we do not spend in the form of the energy, and that carbohydrate gets converted into the fat and deposited in the liver. That is called as de novo lipogenesis. That's why we always say if you will reduce the carbohydrate content in the diet or in the food, probably you may be able to control your diabetes, insulin resistance, and FLD, and all diseases which are associated with the insulin resistance. So as I could say, and I could make you understood well, that this free fatty acids is the largest contributor of the fat deposition in the liver, and once this fat deposition comes in the liver, as it is already associated with the continuously increasing insulin resistance, which is not only giving rise to the alpha cell increased secretion of the glucagon, beta cell decreased secretion of the insulin, at the same time more of the amino acids are released, and lot of environmental genetic factors are also responsible, what has been very well explained by my previous speaker, Dr. Arun Kedia, in his one of the slides. And ultimately, not only it leads to the obesity, not only leads to the liver dysfunction. I am not much worried about the cirrhosis which will be developing after 10 years or 20 years. I am more worried about the conversion of this fat into the VLDL, triglyceride, and reduction in the level of the HDL, which is the protective cholesterol, and that will make my youngsters into the cardiovascular disease, make my youngsters to get the heart attack in their early life. So how can we really diagnose it? So if we really wish to diagnose this, there are multiple things in which the liver biopsy and many investigations are there. Suspected NAFLD in whom the competing etiologies for the hepatic steatosis and coexisting chronic liver disease are there. Probably they can be diagnosed by the NAFLD fibrosis score, as well as which can also be taken with the help of ultrasonography. Imagination is one of the important methods through which we can diagnose. Liver function test or AST-ALT ratio is one of the factors, but as I already told you, it is having its limited value in the diagnosis of the NAFLD. Biomarkers are having its more value in the diagnosis of the NAFLD, in which cytokeratin 18 fragment CK18 is one of the most important and promising biomarker, apart from the other metabolic biomarkers like HOMA-IR and inflammatory markers like CD8 protein. Triglyceride to HDL ratio is also used as a surrogate marker for the NAFLD. Clinical presentation is most of the time it is without any symptom. It remains asymptomatic in majority of the patient. So every diabetic patient, every patient who is having the obesity, every person who is having the weight gain, he should be explored for the NAFLD. The evaluation and management of the NAFLD in patient with type 2 diabetes is always a call to action, and it should be done in each and all patients of the type 2 diabetes. And it's not only by the simply enzyme test of the liver function, but also other methods should also be implemented if we do not find the raised enzyme. AST-ALT ratio does not rule out the NASH most of the time. Scores for the identifying advanced fibrosis in NAFLD is important, in which this FIB4 is one of the very promising score apart from the NAFLD fibrosis score. Any of these scores can be used for the diagnosis of NAFLD. FibroScan are also important tools for this, in which we can go with the vibration control transient elastography to diagnose the liver with fat deposition. Liver biopsy is the confirmative test. Lifestyle modification is the most important thing which could be done to get rid of this fat deposition in the liver and NAFLD. Multiple ways of the lifestyle modification, 500 to 1000 kilocalorie energy deficit is required to induce a weight loss. In any way someone is going to have the weight loss, it will be helping in reducing the NAFLD. Fructose containing beverages and foods and saturated fatty acid should be avoided. There has been some studies in which it is said that regular coffee consumption of 2 to 3 cups in a day is known to decrease the risk of the hepatic fibrosis. So you can use that. So I will finish in 1 or 2 minutes next. So lifestyle modification is a key approach for NAFLD management. Lot of medications are prescribed and are suggested for the NAFLD, but most of them are off-label, like metformin, vitamin D, PPR, gamma agonist, UPA, pentoxifylline, GLP-1 agonist, UDCA, obeticholic acid. They all are being used, but none of them is sure shot. But the most important thing, all medication which are reducing the insulin resistance, they will be helping you in getting rid from the NAFLD. But unfortunately, those who are reducing the insulin resistance, they are mostly the anti-diabetic medication. And they can only be given if your patient is having the diabetes together with it. Apart from that, we have developed recently the saroglitazar, and we could see that it can reduce 45 to 62% of the triglycerides, 21 to 36% of the non-HDL, 20.3% of the small density LDL, and 0.7 to 1.6% HbA1c reduction, and enzymes, liver enzymes are also reduced up to the 28% to 67%. So this is most likely at present is one of the most promising drugs, having a very good results of decrease in NAFLD activity score, and even for the NAFLD and NASH, this particular molecule has also got the approval of the US FDA. The statins are important, although they have little effect on the NAFLD, but they are very much important to avoid the cardiovascular adverse outcome. Omega-3 polyunsaturated fatty acids are having some say over the occurrence of the NAFLD and cardiovascular disease. Vitamin E has been found to be reducing the oxidative NAFLD and type 2 diabetes. Pentoxifylline is a non-selective phosphodiesterase inhibitor, has a role in decreasing the inflammatory pathways such as TNF-alpha, and it has got the mixed results on the plasma aminotransferase and hepatic steatosis. On imaging has been established with some studies. Metformin and all the anti-diabetic, including the pioglitazone. Now the pioglitazone has been prescribed by the Organization of the Gastroenterology for the NAFLD and NASH, even in non-diabetic individuals also. Glucagon-like peptide, GLP-1 analog are also having studies, DPP-4 inhibitors. But fortunately or unfortunately, we can give these drugs only those who are having the diabetes. Bariatric surgery is also having its impact on the NASH and non-cirrhotic NASH as well as in the NAFLD. Follow-up guidelines for the NAFLD patients are there. NAFLD patient without worsening of the metabolic risk factor should be monitored once in every 2 to 3 years. If a person with a NASH is there and having the fibrosis, then he should be monitored annually. NASH with cirrhosis should be monitored once in 6 months. NASH with high risk of the progression should be monitored with the liver biopsy after 5 years follow-up. And NASH patient with fibrosis and hypertension should have a close monitoring because of a high risk of the decreased progression. NASH with cirrhosis should be screened for the gastroesophageal varices and hepatocellular carcinoma. So conclusion is that fatty liver is a major determinant in the development of the type 2 diabetes predisposed individual. However, once type 2 diabetes is fully developed, not only will it further contribute to the steatogenesis, but also contribute to progressive liver damage including NASH, fibrosis, cirrhosis, and possibly to the hepatocellular carcinoma in a subset of patients. On these grounds, diagnostic and early therapeutic interventions are warranted in treating non-alcoholic steatohepatitis patients at risk for developing type 2 diabetes, as well as to prevent or make an early diagnosis of progressive liver disease. All those who are having the type 2 diabetes should be screened for NAFLD or NASH. Thank you very much for your kind attention.
Congratulations, Professor Anuj Maheshwari, for wonderful and lucid talk on a very vital subject. The message which you have given is loud and clear. By the time we diagnose diabetes mellitus, 50% or more of beta cell functions are gone, and maybe the clinical process has started way back. And non-alcoholic fatty liver disease is one of those conditions where you should be on alert. And second thing is, what he has emphasized upon is the dietary modification and reduction of body weight so wonderfully well. So this is the time to get alerted when we get a fatty liver on there where the days when we used to get fatty liver on ultrasound and we used to pass them off as just a benign entity. Now this is the time to investigate that and look for other things. Now the stage is clear for any questions coming up from audience.
In fact, as I already said, in the meantime anybody is coming with a question. In fact, as I already said, the more important role in this prevention is the physical activity. less important is the diet management. Because diet's contribution is much lesser and IR related contribution is much higher, and IR can only be reduced by the physical activity, more and more physical activity. You cannot reduce, because you cannot give in a non-diabetic individual any anti-diabetic. You cannot give metformin, you cannot give pioglitazone, you cannot give saroglitazone, those who are not having the appropriate indication. But you can always ask the people to run, to walk, to do the physical activity, go to gym, do the maximum exercise.
Yeah, I agree with you, Professor Anuj Maheshwari. Of all the modalities of the treatment which has been seen in the type 2 diabetes mellitus, one thing was very clear: bariatric surgery showed remission. When very low calorie diet was given to the person, the peripancreatic fat in the rats started melting just 48 hours after that. Well, the debate will continue, diet or exercise, which is more important. Naturally, as an insulin sensitizer, the exercise is very important. Aerobic exercise increases the insulin sensitivity by 40%. Non-aerobic exercise, resistance exercise by 40%. And there is no insulin sensitizer better than exercise. Well said, in a normal individuals who are non-diabetic, exercise will be very vital.
Thank you, thank you. Vitamin E is supposed to be given in 700 milligram, ideally the dose which is recommended for that. Usually we get the capsule of the 400 milligram, usually 2 capsules. Yeah, so we should try to give the 2 capsules in a day if we are giving for the NAFLD. And if it is, usually it is not recommended for the prevention, it is recommended for the disease only. So if you are giving only for the prevention, you can go with the 1 capsule in a day just for the prevention. How does it work? It's very difficult to say. There is no convincing data, but there are some data that it works in the 700 milligram. If we are giving that, it reduces the level of the NAFLD as well as NASH. It has also helped in reducing the inflammation by reducing the oxidative stress. You know, vitamin E is a very good antioxidant, and it reduces the oxidative stress, which is the mother of all inflammation. So it can help in that. As far as the duration of the therapy is concerned, it can be for lifelong until the disease is there.
It is a good drug. Vitamin E is a good drug, but it should not be given more than 3 months.
No, many people take it for, it should not be given more than 3 months in the therapeutic dose which is recommended, 2 capsules in a day. After that you can continue 1 capsule throughout the life. Even many people give it for the, just even for the cardio protection, for the reason of the oxidative stress. And many a time, yes, you are right in that way. Some people may develop the bleeding disorders also with the hypervitaminosis of the vitamin E. So we should always be careful about the hypervitaminosis kind of the situation.
Dr. Anuj, which of these medicines, apart from lifestyle modification, what is your choice in your day-to-day practice as far as non-alcoholic fatty liver?
If patient is having hypertriglyceridemia, if patient is having the cholesterol disorders, then I would definitely be preferring the combination of the statin with the saroglitazone. Statin for the protection from the cardiovascular adverse outcome, and saroglitazone for the protection as well as for the reduction in the, which has got a very much convincing result. 52% reduction in the NAFLD could be seen, and because of what it has got, when saroglitazone has not got the US FDA approval for the use in type 2 diabetes, for the use in the hypertriglyceridemia, but they have got the approval to use in the NASH, to use in the NAFLD. So for that purpose, this is a very much convincing data it has on the background.
Sir, I have a question. I want to know that you have shown the recommendations by various bodies, like different bodies. None have recommended ursodeoxycholic acid.
None of them
has recommended ursodeoxycholic acid.
Yes.
Ursodeoxycholic.
Yes,
and it is being widely used in our part of the country. So what's your take and your personal message, that what's your clinical experience? And we have seen normalization of ALT levels, biochemical parameters. So that is the reason for its use. But none of them recommend. Someone you said that none mentioned, not mentioned also in their literature. So what's your take on the usage of ursodeoxycholic acid in fatty liver disease?
Yes, I am telling you, very important question, a very appropriate question you have asked that. It must be clarified. Ursodeoxycholic acid is not having role in reduction in NAFLD, in reduction in NASH. It has not been proven yet, for that it is working there. Now question arises, it do reduces the AST-ALT level. It do reduces the level of the liver enzyme. But saroglitazar is having better reduction in the liver enzymes even from that. Apart from that, the biggest conflict with the use of the ursodeoxycholic acid is that when you are using the ursodeoxycholic acid, it increases the level of the triglyceride instead of reducing it. On the other hand, if you are using the saroglitazar, it reduces the level of triglyceride level is also one of the very important contributing factor, not only for the NAFLD but also for the cardiovascular ailment which are harming your patient. So that's why ursodeoxycholic acid is not so much preferred agent for the NAFLD per se. Or for some other thing you can definitely continue using this, but for the NAFLD it is not well recommended now.
The medications which are used in alcoholic fatty liver disease like S-adenosylmethionine and all.
Alcoholic fatty liver disease,
Yeah, the S-adenosylmethionine and all those products. Are there trials on non-alcoholic fatty liver disease also?
I must tell you, non-alcoholic fatty liver disease is such a dubious thing in which even you cannot rely report of the liver enzyme. AST-ALT normal, but still the NAFLD is there. What you can do? AST-ALT is not. I have shown you one slide. It's 20% of the patients those who are having the clear-cut NAFLD, they are normal AST-ALT, normal SGPT. So actually, lowering down of the SGLT, SGOT, status does not directly correlating, well correlating with the status of the NAFLD. And what you have said that I have shown only those medications which have had the data backup or got undergone trial for the NAFLD. What the medication you are telling about, they have not been tested for the NAFLD. They have been tested in the jaundice individuals, they have tested in the hepatitis B or C. They have also gone the trials, you can find them in the alcoholic liver disease. But in NAFLD, actually both are having a very different origin. Alcoholic liver disease is because of the alcohol and its toxic, but NAFLD is coming because of the metabolic reason. It is coming because of the insulin resistance. It has nothing to do with the same reasons what are there with the alcoholic liver disease.
Thank you, sir.
Bambidoic acid is not for the NAFLD, it is for the cholesterol control, it is for the LDL correction. Yeah. It can definitely prevent the cardiovascular adverse effects, but whether it will do something with the deposition of the fat inside the liver, we don't have any data.
Well, I am trying with that drug in the medications of fatty liver.
In future, we can get some kind of data and then we can come out with these kinds of recommendations if it is there.
Your experience with obeticholic acid? Obeticholic acid, your experience?
Yes, I have used obeticholic acid and usually patients are getting some sort of the benefit. Few of the patients lose their weight also, 1 or 2 kg, but we do not have long-term studies in which we, on the basis of what I can recommend that it should be used for this purpose.
The FIT scoring is a good clinical scoring which we have to do, and it's easily available online also. We can do a FIT scoring. But after we get the scoring, it is always important to evaluate it further. If the patient is at risk of fibrosis, then it has to be evaluated with the fibroscan or an elastography. The other thing is, what is your take on an SGLT2 inhibitor in patients with NAFLD?
SGLT2 inhibitor helps in weight reduction. No doubt, they are helping in the weight reduction and they are helping at the cut down of that glucose which is helping a person or which is contributing in de novo lipogenesis. So definitely, if you are treating the diabetes with the SGLT2 inhibitor, it will definitely help in that part, because वो 26% which is coming from the de novo lipogenesis, वो तो उससे कम होगा ही, so definitely it will help there. But as far as we do not have any data through which I can recommend here on the slide presentation that it is reducing the fatty liver disease.
There will be a lot of questions. The interest he has generated among the audience is unmatchable, and we can ask him the questions during the lunch time. For the lack of the time, we have to stop it here with this lecture, and let us give him an outstanding ovation to Anuj Maheshwari. The next speaker is Dr. Anand Sankar, Associate Professor of Medicine at Netaji Medical College and Hospital, and he doesn't require any introduction to this audience. He is associated with all important academic bodies related to medicine and diabetes. He got Best Speaker Award in 2016 by API Bihar chapter, wrote books, publications in index journals, and I will not stand between him and his lecture on a very vital topic of this moving forward, gaining a wider outlook of diabetes management with generation 2 basal insulin. Over to Dr. Anand Sankar.
Namaskar, Speaker Chairperson. Thanks for your kind introduction. Thanks the organizers, especially Dr. Ubaidali, Kamran Khan, Manish, Anand for inviting me here. Thanks Dr. B.K. Singh sir. Today we are here due to Dr. Anuj Maheshwari sir. We must give him a good round of applause. RSSDI Bihar chapter should not have come to this stage if sir is not there. So thank you sir, thank you so very much. The topic given to me is moving forward, gaining a wider outlook of diabetes management with generation 2.0 basal insulin. I think in the morning Dr. Shehbal Guha sir has already spoken quite in detail. So my work has become very easy. Why we are talking about the basal insulin altogether? Dr. Virmani sir has asked this question. The glargine required more than the iodine. So, and Anuj sir and elaborated about the insulin resistance, how to counter these things. Once there is insulin resistance, there is insulinopenia, and to handle all those things we need something which is not interfering the day-to-day life of the patient. Earlier we are testing our diabetic patient with the fasting BP sugar, then it will come the HbA1c. But now we have moved another matrix of the glycemic index parameters. We want to know more about the glucose variability, time in range, and of course HbA1c with the HpCl value. Now we are looking to the molecules more on the PK/PD studies, flexibility of the timing of the giving the doses, and of course we must see the new generation of the medicines are inferior to non-inferior to the older ones, which we have to compare. So where these things stand with the next generation insulin, especially the basal insulin. Beyond HbA1c, glycemic variability and time in range, the key metrics of support to the effective diabetic management. Now the international guidelines also supports it that we must see the glycemic variability because it has a negative impact on the outcomes and complications. Time in range also has been seen having not good time in range having negative impacts. How to do it? We have CGM, and I think this August gathering knowing, and the PG student must be knowing nowadays the CGM we are doing. This is a 24 hours glucose monitoring. We do it continuously. There are different companies are there who are providing it. It gives a 24 hours glucose profile. Fasting and PP is the point profile. When we take the blood fasting and PP, at that time the sugars is recorded. HbA1c is the average profile. In the hemoglobin glycation of 90 days we capture it. And whenever the turnover of hemoglobin increases due to any various condition or physiological or pathological, that may vary. And of course we do a lot of other method of seeing HbA1c that also differs with HbA1c. So we want to know more precise about the sugar value, so that which is needed the CGM. So every day, 24 hours, every 15 minutes or 3 minutes we need to check the sugar. That's a bit difficult. So the CGM we need to do. Now the international bodies has there. They have already laid down that what should be the CGM value for type 1 and type 2. And in the green bar you can see in all the places, that is the time in range. The sugar between 70 to 180, that is the range the sugar need to be there for the lesser complication and good glycemic control. That requires for type 1 and type 2 more than 70% in 24 hours. Older type 1 or type 2 required more than 50%. Pregnancy, type 1 or pregnancy, gestational pregnancy, of course more than 70% is required. So this will decrease the complication and long-term complication of diabetes for type 1 diabetes. So this is very important that we must do. Now how this is going to affect if we are doing these tests? Is this test has some benefit? Of course these tests have benefit. You can see here 64% increase in retinopathy in type 1 diabetes, in 10% drop of time in range, 25% increase of the peripheral neuropathy, and Dr. Modi sir has left. He has given a very nice talk on that. And CKD both, if we have 10% drop in time in range and 40% increase in microalbuminuria in type 1 patient, it is there less than 10% time in range is strong. Of course 5% increase in risk of cardiovascular mortality and 8% causes of all causes of mortality. So you can see this is one of the now major armamentarium to investigate our patient whether it is suits or not. So this is all about the time in range. Now how to position this time in range in the treatment of type 2 diabetes, especially when we are talking in India. We have type 1 and type 2 diabetes. In type 1 we have premix insulin or basal bolus. In type 2 we have diet and lifestyle, which not only fails but it never we follow, neither we or nor our patient follow. Oral hypoglycemic agents, and of course with oral hypoglycemic agents and insulin, and we have different set of combination of oral hypoglycemic and insulins to handle these things. But if this should be simple to the patient, this should be the objective oriented goal, clear direction, validation and empowerment to the patient, and these all will give by the time in range. When patient will see their sugar value, they understand how to handle their sugar value. So morning Dr. Sehwal sir has given talk on long-acting insulin. The another insulin long-acting is U-glycine 300 versus the first generation basal insulin, that is Glargine. And in the time in range or is CGM's profile how it behaves, and you can see clearly the new generation has a better and a smooth glycemic control over the U100. There is less glycemic variability and there is more smooth glucose over the 24 hours when we are using U300 Glargine. The Glargine also allows the flexibility of injection. Usually when we are using U100, we need to give on the fixed time because of its profile, PKD-PD profile. So we have to give on the fixed time. We cannot keep changing the time because it will not work, and there is a more glycemic variability and hyper and hypoglycemia will occur more. So the flexibility was not there with the patient, but U300 gives this flexibility. You can use this within 3 hours plus and minus with the same values of the glycemic parameter. So flexibility is one of the reasons why we are moving towards the new generation basal, long-acting basal insulin. So glargine 300 may allow more flexibility in the timing injection to deal with the sustainable and very expensive in daily life. Now glargine 300 demonstrates lower nocturnal hypoglycemia glycemic variability compared to the first generation basal insulin. This is very important because when we are giving basal insulin, so we are improving the basal level of the insulin, which is which reflects in the fasting blood sugar, and fasting blood sugar is handled by the hepatic glucose output. So we want to see whether the nocturnal hypoglycemia is there or not with this insulin. Earlier nocturnal hypoglycemia has been seen, so we have to decrease the dose, and subsequently there is increased hyperglycemia in postprandial. So we need to see whether this insulin is better or not, and you can see the glargine compared with the 100 and 300, there is 2 times less nocturnal hypoglycemia as compared to the older insulin. So this is an insulin which gives a less hypoglycemia with the same smooth profile, and that increase the adherability to the patient and their complication. So comparing the second generation basal insulin in the light of the glycemic variability and time in range, and these are the study from PKPD type 1, and different author has done this study. RCT has been done. Real world evidence is also done in type 1 and type 2 both, and what they have come out that the glargine U300 trial used with the CGM and TR as compared to the IDEC 100, what they have said is 20% less day variability with the glargine 300 with IDEC 100, and glargine 300 provides less fluctuation steady state of PK, PD, and more eventually disturbing the PK versus the IDEC 100 in the body morning dose of 0.4 mg. So this is very important. We need a more smoother insulin with less variability and more compliance to the patient and flexibility to the patient. Further data demonstrate lower variability with the glargine 300 with the IDEC 100, 20% greater insulin peak with the guiding 100 versus glargine 300. So initial hours there is a peak, but later on it settles down. But in G300, the initial hour peak is not there. So it gives more smoother control. So more flatter profile. What we need with the basal insulin, we want a flatter profile, but same times we need a more smoother. So smoothing is more with the G300 as compared to IDEC 100. And so it have 23% less day-to-day variability with glargine 300 with IDEC 100. Now type 2 diabetes CGM study has been done time and range with glargine 300 by IDEC 100, and to compare the efficacy and safety of the glargine 300 IDEC 100 on the glycemic control using CGM, and they have randomized 15 patients in the both arm, and to compare that they have compared with glargine 300 IDEC 100 with a TBR markedly lower in the glargine 300 as compared the all category of hypoglycemia. So we are more concerned of hypoglycemia when we are giving insulin, and here we have all cause of hypoglycemia less in the glargine 300 as compared to the IDEC 100. Now this is a plus plot because we are not having all the time with the CGM, so we need to do the glucometer testing also. So what is the difference when we are using glucometer? And you can see this study to compare the efficacy and safety of G100 with the IDEC 100, G300 with the IDEC 100 on glycemic control using FGM, and they have seen that there is a good number of patients have less nocturnal hypoglycemia with G300 as compared to IDEC 300 with IDEC 100, and this is very important because we have less initial hour surge effect and more smoother effect with the G300. This is one care with a real world study in adult type 1 diabetes using CGM glargine 300 with iodine 100, and they have a arm in which they have compared with 104 and 95 patient, and you can see TBR in the green bar is iodine 100 and blue bar G300 is non-inferior. Numerically it shows that G300 is superior than the iodine 100, but is non-inferior in the post all-day periods and nocturnal hypoglycemia both. You can see between 100 to 140, 70 to 140 mg per day sugar. So this is very important. At least it is not interfering with anything. You can use it safely. Now coming to the, of course, when we have now basal bolus, because basal insulin not only able to control the sugars in all our type 2 diabetic patients, so we need to basal bolus. And here is a comparison with the basal bolus of G300 with the glulisine and iodic apps, and they also shows that G300 with glulisine and iodic apps has less hypoglycemia 7 times and 18% less nocturnal hypoglycemia and better time in range profile. So here we have to give 2 times glulisine and 1 times G300 in comparison with twice daily additives. This again in range 3 and G300 iodic 100 in type 1 patient study has been shown that this is the continuation of a study, G300 open level and G100 open level treatment, and primary or secondary endpoint was there with TIR 70 to 180 with 12 weeks and glucose total coefficient variant at week 12 as glycemic variability at secondary endpoint. And what they have shown, absolutely you can see both have the almost similar. So this is a non-inferior. So nothing that one is superior or better, or though both you can use in type 1 patient or in type 2 patient in the basal insulin because they have non-inferiority data associated. So in range study, for RCT comparing G100 with iodine 100, the type 1 patient using TR endpoint, primary endpoints as non-inferior in the glycemic control, secondary main secondary endpoints non-inferior to GB, and hypoglycemia and safety, similar occurrence of the hypoglycemia with no unexpected safety findings have been seen in both the long-acting basal insulins. So coming to the quality of life, when we are using insulin, that is a very important because that decreases the quality of life. Patients are very susceptible to insulin. When we say we have to start insulin, they first is a denial. They don't know how to take insulin. So what happens with that? You can see here the greater improvement of quality of life and treatment satisfaction in relation with the premix and secretive insulin glargine. And you can see the quality of life is improved. Patient himself have said that it is better in 20 weeks time. This is along with the OIDs. This is a bright study with glargine 300 and shows improvement of diabetic treatment satisfaction. These are question answer score based bright study, and you can see glargine 300 and glargine iodine 100 both has been shown as a better quality of life is compared to the earlier insulin. This is the same improvement of hypoglycemia attitude. Patient is more concerned about the hypoglycemia, and this study has shown that patient concern of hypoglycemia is also improved. They are more confident using insulin when we are using all newer glargine 300 insulin. One care study also shows a high treatment satisfaction, not only the quality of life. Patient satisfaction is also with glargine 300 as compared to iodine 100 is more, and satisfaction with the treatment using DTS was compared with the glargine 300 iodine 100. The treatment score was a 2.8 score, reflecting high treatment satisfaction with the both insulins. So, dear friends, the newer insulins are there. We need to use at the right time at the right dose. So, glycemic variability and suboptimal TIR can be significantly impact the lives of the patient with the diabetes. G100 allow a dose flexibility plus minus 3 hours in time injection to deal with the patient variability and the speaking of the daily life. Numerous trials using CGM and TIR profile has been demonstrated that the G300 provide effective and sustainable glycemic control over the incidence of glycemic variability. This use of G300 is associated with the lower incidence of overall nocturnal hyperglycemia. Thank you so very much.
Excellent talk, Anand. There are people in favor of degludec. There are people in favor of 300. Nirmani sir talked eloquently about 100 also glargine. Now, the House is open to the question, and you have to, one thing you clarify, whether these studies showing superiority of Glargine 300 over Degludec, whether they were Sanofi and other pharma sponsored or this thing. Or similarly, studies showing superiority of Degludec over Glargine 300.
Sir, both
because the fight is very interesting. The fight is very interesting.
Sir, there is nothing to fight. We cannot fight in the sulfonyl ureas. That okay, this is we choose only this. There is no fight on the glitazoles. There is no fight in the SGLT. So there is no fight on the insulin. Only what are the evidence on the particular molecules are there. We have to see. IDEC apps
and who is providing the evidences?
IDEC apps is also a good long-acting insulin. G300 is also a very good long-acting insulin. IDEC apps has a little longer half-life than the G300. Of course, both are superior than the NPH and G100, and of course Tetimate. Now we have to choose which patient required which type of insulin. The evidence what you are asking, the real world evidence are not from the sponsors. The RCTs are, few RCTs are from the company development phase. PKPD studies are done the company development phase when they are developing the insulin. But after that, the RCTs are not from, once the development is over, so it is open to the market. So a lot of study has been done after it is launched. So those studies cannot be biased, taken as a bias. Only I agree with your point, what you want to highlight, the number of the sample size. Of course, number of sample size are less to give a clear-cut conclusion that IDEC 100 or G300 which is superior. I cannot say that, because we have to go back and then do a head-to-head trial, which is not possible.
Duration of action is immaterial between 300 and this thing, because what we want is the glycemic control over 24 hours. So where does it matter if one has 36 hours and other has 42 hours?
That's what
glycemic variability, and particularly during nighttime hypoglycemia, that is the most important clinical point a physician or diabetologist is concerned about.
That's the only point I was highlighting.
And you finish up, and I would like to invite Sehwal Guha into this discussion and provide his point of view.
All basal insulins are equally effective. There is sufficient real world data to show that all basal insulins are equally effective. The only difference is in the incidence of hypoglycemia, especially nocturnal hypoglycemia, and the longer half-life, or the exact between NPH, is the differences between NPH, Glargine and Degludec is their half-life, and the lesser incidence of hypoglycemia, especially nocturnal hypoglycemia with the later generation insulins. That's the only difference. But if you are looking at reduction in fasting plasma glucose or fasting blood sugar, it's absolutely the same. There is no difference.
And one point, sir, what in the last talk, Dr. Virmani sir has raised, why we need little more G300 than the IDEC 100. That is what you have explained, sir. That is absolutely correct. Because it becomes a depot. It is in the subcutaneous. So albumin has to bind it. And once the albumin start binding, it has to carry. So that difference will be remain. That's why we are not using all fast-acting aspart in all patients.
The purpose of saying that was, instead of using U100, there is no sense in using 300 unless the dose is...
Absolutely, sir. Absolutely. That's absolutely. I was expecting Anand, sir.
Anand was wonderful lecture, as always. I have practical, only two points to make.
Very short, very brief and to the point. In usual clinical practice in Bihar, most of the patients are on premixed insulin, so 30-70, 25-75. These kind of patients. Now you talk of glycemic variability. We all understand that glycemic variability is very important. But what practically we do is we monitor our patients with HbA1c. Getting CGM for all our patients at this point of time is not possible. So suppose a person has a HbA1c of 6.9. So would you recommend U300 to these patients on a premix insulin? 1. 2. How will it switch? Suppose the patient is on a 25-15, how will it switch to U300? These are two practical questions.
6.9 HbA1c.
Why should you
patient on premix insulin?
You are talking of the advantage of glycemic variability.
I'm coming.
Yes.
I'm coming, partner.
A person HbA1c is not going to reflect glycemic variability.
Let him make a first answer.
Okay. First, it is not feasible to do CGM to all patients in our clinical practice. What Amit has said is absolutely correct. I'm 100% agree with Dr. Amit. And to know the glycemic variability in our patient without CGMS, we can do point testing multiple times, as Virmani sir has given his talk in Jharkhand, in a Manas observation. 7-point test, sometimes 7-point test, 7.5-point test, and sometimes 9-point test. Okay, so from there you can get a brief idea that whether this HbA1c is a true glycemic control reflection or not. Okay, now suppose you have done 5-point test and postprandial hyperglycemia is evident, but fasting and preprandial hyperglycemia is normal. This is what happened with the HbA1c when it is lower. Okay, so what you do? You need to increase those agents which can decrease the postprandial hyperglycemia. Here, the role of insulin, long-acting insulin, is minimal. Increasing a long-acting insulin in such a case will absolutely produce nocturnal and early morning hypoglycemia. So here we have to use those agents which predominantly control the sugar in postprandial period. This you want to know. Now suppose a patient postprandial is okay, but the fasting is high and HbA1c 7.9 and patient on the premixed insulin. Then we have to see the midnight sugar value first. Whether they have a midnight hypoglycemia reflecting morning hour hyperglycemia, then only we'll able to tell which insulin to be used. And the second question we have asked, switch. There is no point of switching.
Right. On the request of the chairpersons, may I present the consensus statement? And I may be corrected if I am wrong. Point number 1, as I said, all basal insulins are good. Even if the patient is stable on NPH, that's fine enough. It works. If it's good working for that patient, don't need to change. Number 2, all the factors about lesser nocturnal hypoglycemia, lesser hypoglycemia in the initiating phase, these are all technical jargons. The only thing is the newer basal insulins have lesser hypoglycemia incidence than the conventional one. Now the third point is the USPs of the different insulins. The USP of degludec is the flexibility part. That is there, which is not there with other insulins. The USP of glargine U300 is in case, as Vinwani has rightly pointed out when I was talking, in a patient who needs a large dose of insulin, then we should prefer the degludec U300 because that is gives the patient less pain, less volume is injected. And U100 is obviously the most time-tested basal insulin. Right, am I right?
Yes.
Thank you.
That was
yes, sir.
That was a very good consensus.
Yes.
The USP of database is to be used in
pregnancy, right, sir?
And obese person.
Obese, yeah.
Does not cause weight gain.
Thank you, sir.
Sir, recently Novo people have come up with the studies showing the safety of degludec in pregnancy also. Recommendation is not there, but they have come up with evidence. So, for the lack of time, let us close the session now and invite Manish to the dais to invite people from the next session.
Thank you so much, speakers, for the third session. And may I request our chairpersons to honor our speaker, Dr. Anuj Maheshwari and Dr. Anand Shankar. May I request Dr. Anuj Maheshwari, sir, to please come on the dais. Dr. Anuj Maheshwari, sir. Dr. Anuj Maheshwari, sir, to be honored by our chairpersons. And chairpersons to honor Dr. Anand Shankar. I request our two speakers to honor our chairperson. Dr. Sudhir. Dr. Sudhir, honor Dr. Sudhir. Dr. Abhilesh Kumar sir. And Dr. Rajiv Sinha sir. Thank you so much, chairpersons and speakers, for this session.
From my PG sides, big hands for the speakers.
Thank you so much, speakers and chairpersons. May I request speakers for chairperson for the next session, Dr. Anil Kumar Virmani sir, Dr. Shaibal Bua and Dr. Kamran Khan sir, to please come on the dais.
Good afternoon, friends. We'll start with the next session. And we have none other than the chairperson of the Bihar RSSDI chapter, Dr. B.K. Singh. I don't think he needs any introduction. He is the doyen of Bihar. And he'll be talking about diabetes in young. Now, today we are seeing a lot of patients of type 2 diabetes in the age of 18 years and 20 years. And it becomes a dilemma, what is the cause? Is it type 1? Is it type 2? Is it monogenic? Is it MODY? Is it LADA? So there are lots of subdivisions of diabetes. And I'm sure he's going to throw a light on them. Over to you, Dr. B.K.
Thank you, chairpersons, Dr. Nirmani Shah, Dr. Sehwal and Dr. Kamran, and the audience, delegates, and the people of Bhagalpur. As you know that diabetes in young has been classically defined as onset of diabetes at or below 25 years of age. There is a controversy regarding the age. In Western population, age of onset is diabetes is higher, so the upper limit of the age of young children are also higher, around 35 years or the 40 years. But in India, it is taken as the diabetes below 25 years is considered to be diabetes. It is estimated that in nearly 77 million individuals have diabetes, and it is expected to increase to 101 million in 2030. As per the ICMR young diabetic registry data, nearly 64% patient have type 1 diabetes mellitus, but now the trend is changing. Type 2 diabetes mellitus is increasingly being reported in young adults, and as per observation of the South et al., the prevalence of type 2 diabetes mellitus and type 1 diabetes mellitus in young in India is almost equal, nearly 40%. The probable reason or reasons for the increasing prevalence in India, there is a highest rate of progression from pre-diabetes to type 2 diabetes in India, nearly 40 to 80%. And there is a 60% of the population of India are young, and so the prevalence is increased in 25 years of age. The most important part is the increase in obesity, the most habit, lack of exercise, increased level of stress, intake of high fat and refined carbohydrate in diet, and the epigenetic factors are also very important for causes of type 2 diabetes mellitus in young. There are 4 major types of diabetes in India, that is type 1 diabetes, type 2 diabetes, the gestational diabetes mellitus, and other forms of diabetes mellitus like MODY, pancreatitis and the endocrine diabetes and other genetic and secondary diabetes. Considering the type 1 diabetes mellitus in India, the type 1 diabetes mellitus is characterized by the autoimmune destruction of beta cells that leads to the insulin deficiency, and about 90% of the patients have detectable autoantibodies. And the type 1 diabetes is the most common form of diabetes in children below 10 years of age, and the incidence of diabetes mellitus is rising worldwide. Countries with highest estimated number of new cases annually are USA, 13,000, India 10,900, and Brazil 5,000. In spite of that, you can see that India is in the second position as the number of type 1 diabetes mellitus in India is concerned. In India, there are 3 new cases of type 1 diabetes mellitus, 1 lakh children of 14 years, and there are 2 types of type 1, the immune-mediated and idiopathic, as you know. The clinical picture wise, you can diagnose this or you can suspect this type 1 diabetes mellitus at abrupt onset can be treated with the ketoacidosis. Usually non-obese, family of diabetes mellitus may be absent, and the severe diabetes mellitus with low and absent level of peptides. The autoantibodies may be present like GADA, GAD, or IL-2 or gene transporting 8 inhibitors. Patient require lifelong insulin for survival. HLA-DR4-TQ8 and HLA-DR3-TQ testing may be required if the patient is having type 2 diabetes mellitus, and treatment is insulin by injection or the insulin pump or monitoring is required through the SPG or the CGM. The type 2 diabetes mellitus, on the other hand, one of the most commonest type of diabetes affecting this group, and nearly more than 40% of the total diabetes mellitus study is of type 2 diabetes mellitus in India. The diagnosis can be made by the following features: the presence of obesity, features of insulin resistance, that is acanthosis, skin tag and alert, the strong family history of diabetes, good significant response, and absence of autoantibodies. There is a response to the oral hypoglycemic agent, and most of the patients are asymptomatic in the young age patient, and classical symptoms may not be present, and usually the symptoms like tiredness, lack of concentration, and lack of interest may be the clinical symptoms in young diabetic patients. Youth diagnosed with type 2 diabetes mellitus are more prone to develop comorbid complications like hypertension, hyperlipidemia, and other diabetic complications in early years. And in fact, adolescents with type 2 diabetes have 50% lower insulin sensitivity and 75% lower first phase insulin secretion when compared to with the non-diabetic adolescent measured for the similar BMI as well as abdominal adiposity. The management, all you know that the lifestyle modification is the cornerstone in this, and standard diabetes education program. Metformin is the drug of choice, latest Arparia, can be added as per the need, and other drugs like linites, glucosidase inhibitors, glitazones, and DPP4 inhibitors are not recommended yet. Frequent monitoring is necessary, and it is very difficult to achieve glycemic target due to the physiological, pathological, and psychological factor in the type A diabetic patient in India. The third most important one is that we may miss in the patient of the diabetes in India is the MODY. In diabetes, this is caused by the mutation or variation of single gene. MODY is not uncommonly, it is missed in young diabetes patients, and these patients are often misdiagnosed as a type 1 diabetes mellitus and treated with the insulin. Though it is not as common as the Scandinavian people, limited source of genetic testing may be the reason for the underdiagnosis of monogenic diabetes mellitus. Number of MODY have been increased significantly in recent years, and from 6 to the more than 13 yearly 40 different specific genes are present to classify the MODY patients. And the diagnosis can be suspected when the patient of onset of diabetes is below 25 years, abdominal, autosomal dominant inheritance and absence of ketosis, and these are controllable with insulin, and the clinical diagnosis is no longer acceptable, and the genetic testing is mandatory to confirm the diagnosis and classify the different type of MODYs. The targeting treatment to the genetic etiology, many of the patients of monogenic diabetes may not need insulin, like the G6K MODY, no treatment is required, and if the HNF1A and HNF4A MODYs present the ASU sensitivity and is the patient, and so the patient may be treated with sulfonylurea, and the CV risk with HNF1A MODY statin if the patient is more than 40 years of age. The neonatal diabetes mellitus, the KCNJ11 for A, B, C, C, D, 8 in region patient, insulin is not required, and high dose of sulfonylurea is the treatment of choice in the neonatal diabetes mellitus. The management of pregnancy, most important, the MODY2 like the G6K MODY is most prevalent in the pregnant patients and usually confused, and so the treatment depends upon the fetal and maternal genotype and the abdominal girth of the patient. So there are the other diabetes mellitus present in this young people is the fibrocalculous pancreatic diabetes mellitus, and predominantly limited to the tropics characterized by the pancreatic calculi on X-ray or ductal dilation, ketosis resistant lean diabetes, progressive and irreversible destruction of pancreatic parenchyma, good initial response to the diabetic medication, and high risk of carcinoma of pancreas in the long run. The patient, so patient may be screened for the carcinoma if the patient is diagnosed of fibrocalculous pancreatic diabetes. The classical triad of tropic calcific pancreatitis is recurrent abdominal pain, steatorrhea, and diabetes. Etiopathogenesis remain unknown. Poor nutrition and malnutrition has been implicated as a possible factor. Dietary toxins such as cyanogens intake and micronutrient deficiency may be a possible factor. Some protease inhibitor cathal-1 gene variation may be associated with FCPD, and FCPD contributes significantly to burden of diabetes in young in this part of the world, but now it is a decreasing treatment. Insulin is needed, and you can maybe controlled through the OHS, and the replacement of pancreatic enzyme is an important factor, and careful screening is required for the pre-malignant condition. So gestational diabetes is already been discussed by the previous speaker. Glucose intolerances developed during the second and third trimester. Most CDM revert to the normal in postmortem period, but with 30 to 60% risk of future development of type 2 diabetes mellitus. Glucose intolerance detected the first time it is called pre-existing pre-gestational diabetes by the ADA, and the DFCS suggests a single-step procedure to screen the GDA patient. Treatment is lifestyle modification, medical nutrition, insulin therapy, and other drug like metformin and glucagon may be used if the patient is reluctant to take this insulin. So other type of diabetes, drug-induced diabetes may be due to corticosteroid, like antipsychotic drugs, may produce hyperglycemia in susceptible individuals, and young are not an exception. And the diabetogenic drugs can impair insulin secretion or action and result in diabetes may be transient or sometimes permanent. The secondary diabetes is developed as a consequence of other diseases. Many endocrine diseases may cause secondary diabetes like glycosylation, glucogonoma, and other important type of diabetes, mitochondrial diabetes. It is caused by poor functioning of mitochondria due to mutation of mitochondrial DNA or the nuclear DNA. So how to approach this patient? You can approach through the patient. First you see the age of the patient. If the patient age is less than 6 months, most of the diagnosis is more or less of congenital or neonatal or diabetes mellitus. More research studies showed that the monogenic form of NDM may be still occurring up to the 12 month of patient, 12 month of the age, although with reduced percentage. So molecular diagnosis of genetic diagnosis is important to rule out the congenital and neonatal diabetes mellitus. If the age is more than 6 months to 10 years, the type 1 diabetes mellitus is more common, and monogenic diabetes may be considered. So C-peptide test and pancreatic automated test is required to rule out the type 1 diabetes mellitus, and genetic testing may be required to confirm the diagnosis of MODY. If the patient is more than 10 years and up to the 25 years, this represents the majority of young diabetes mellitus, and complete workup including the urine, ketones, serum glucose, C-peptide, plasma insulin, other autoactivities, liver function fundoscopy may be done, and if sufficient, if you suspect in the case of monogenic, then genetic testing may be the factor. So by age you can outline that what may be the cause of diabetes in younger patient. That is a beautiful elaboration. It is adopted from the Dr. Mohan et al. By Dr. Mohan, is suggested by Dr. Mohan. This is a very beautiful article. You can see that the diabetes, if you are suspecting that the patient is you are seeing the patient of diabetes in here, you have to see whether the family history is positive or negative. If the family history is positive, and if this diabetes is present in more than 3 generations, if the answer is yes, the ketonuria is negative, C-peptide good response of the OHS, MODY gene should be tested, and you can consider it the patient of MODY. If it is not present with the 3 generation ketogenic negative CPAP good response to HA, family history of diabetes in one or both parallel, then you can consider it is a case of type 2 diabetes mellitus. Similarly, if the family history is negative, ketonuria is positive, C-peptide absence, you may consider type 1 diabetes mellitus. It is of 2 types, autoantibodies positive and autoantibody negative, like autoimmune type 1 diabetes and idiopathic type 1 diabetes mellitus. If the family history is negative and ketonuria is negative, C-peptide pure, abdominal X-ray you can do occlusion, and if you can find the pancreatic and colonic region, FCBT, one of the factors for that particular region. Or if the patient in diabetic presence in the first onset in pregnancy, then you can consider it as a case of hyperglycemia in pregnancy or GDM. If the other endocrine disorder present, maybe the secondary cause of the diabetes mellitus or endocrine disease, or you can see that there are other genetic factors are present in their genetic mutation and marker may be advised, and the patient may be conditioned for genetic disorder of diabetes. So this is all about the differential diagnosis. Non-obese patient we have already discussed. The non-obese patient with diabetes without family history, then you can consider in the type 1 diabetes mellitus. If the feature of metabolic syndrome is present, you can consider in the type 2 diabetes mellitus. There is a high index of suspicion required to diagnose the other form of the diabetes mellitus, and the routine and affordable genetic testing are now available in India. So a more judicious use of a clinical phenotype is necessary to diagnose and treat the different type of diabetes mellitus. So to conclude to my talk, the incidence and prevalence of diabetes in young are increasing not only in India but in globally. Early detection and differentiation are necessary to plan treatment. Childhood obesity is increasing day by day due to unhealthy lifestyle like high calorie junk food and sedentary behaviors. And the management is really challenging in this group of patients due to physical, social and emotional growth. Future research is needed to halt or reverse the diagnosis or complication. But if you can use this logarithm, you can diagnose or suspect the different form of diabetes in young. So thank you very much for your patient hearing, and I will be giving time.
Thank you, Professor, for wonderfully describing in very simplistic words how to approach a patient of diabetes in the young age group by using clinical and biochemical parameters. If there are any queries or questions or suggestions from the audience, they are welcome.
Dr. B.K. Singh, excellent talk. Let me ask a question to the audience, not to you. We have got a lot of experienced diabetologists here, we got busy students here. What is the youngest age of type 2 diabetes you have seen in your clinical career? I mean, first the seniors, sir. You must have seen a lot of patients of type 2 diabetes at a very young age. What is the youngest age you have seen? Dr. D.P. Singh? 20. So now we are seeing patients at a very young age, 18 years, 20 years, as type 2 diabetes. Am I right, Dr. B.K. Singh?
Yes, sir.
I think PG should note that, because you have given an excellent differential diagnosis of how to approach a patient who is coming at the age of 20 years with high blood sugars, and how to reach the right diagnosis. Thank you.
Thanks.
Next.
I have a question rather, BK sir, and from the audience also. Of late we are seeing that we are having multiple n number of young adult patients, especially below the age of 24 years. And if we consider them to be type 1, if they are of less than 20 years, we go for anti-GAD65 and it comes to negative. And then we have two options left in our mind, type 2 or MODI. So we have an algorithm of 3 generations, which is typically very much accurate to depict somebody as having MODI. So this is a very important point, because genetic studies are not very much common, and this cannot be done to each and every patient. So anti-GAD65 and proper history taking of all the generations can make us land to the diagnosis as a MODI, someone as having MODI.
Yes, you are right. You rightly point out that the patient, by high index of suspicion, you can diagnose the patient of MODY also. Particularly in pregnancy, GDM Dr. Arun Kedia has rightly pointed. One thing is that many of the patient of in pregnant patient comes with the diabetes. You may consider it the MODY because the presentation of MODY and MODY particularly G6K, the MODY 2, which is not uncommonly, even one study in the recent study that nearly 10% of the GDM patients may have G6K deficiency MODY 2 in pregnant women. And the treatment is quite different in the GDM and the MODY, the monogenic type B or G6 MODY 2 is present in the pregnant patient.
I think there has recently been a change in the way we label MODY. Earlier we used to say that MODY can be diagnosed only by history, 3 generations history. But recently ADA and other, even the IDF, they have mandated that if you want to label somebody MODY, you have to get a genetic testing done. Otherwise you cannot label him MODY. That's the latest recommendation.
Right, sir. Right.
So genetic testing is a must today.
Now it is available also in Chennai, Dr. Mohan Diabetes Center.
So, thank you, BK sir. Over to Dr. Manish.
Before we move on to next speaker, I have an important announcement to make. We are going to have a workshop in the hall B, and Dr. Subhash from Patna will take care of the workshop, and our postgraduate students, both from Bhagalpur and outside, they are very keen and they have made a skit and all. So those who are interested may join for the workshop. May I request the chairpersons to invite the next speaker?
Yeah. Next we have none other than the young erudite and dynamic Dr. Amit Das from Muzaffarpur. He is an excellent speaker and a very active person in the diabetic body. He is in the governing body member of Middle Zone and is chairman-elect of API Bihar and the organizing secretary of the last Bapicon we had. So over to you, Amit.
Thank you, sir. Thank you for the kind words. We all respect Modi. Without a disclaimer of this statement, it's not a political, but Modi is very common. Thank you, Dr. B.K. Singh sir, for setting the stage, and I would request the postgraduates to stand a few minutes before I end my lecture. So today I'm going to talk on a topic which has just been touched by Dr. B.K. Singh sir, and I'll just talk in details. Normally it has been discussed in scientific world as a research tool, and normally it is thought of only diagnostic or a research tool. Today I am going to talk on the clinical aspect of this very topic, and what I am talking, I am sure almost all of you in the hall, whatever left, must be knowing. I am talking of C-peptide and its clinical implications. So I bring greetings from Muzaffarpur. This is the sweet, juicy lychee which you are going to get in next 2 months. I will be inviting all of you to come down to Muzaffarpur for this sweet, wonderful lychees that we have. It's one of the best in the world, having a GI tag associated. So this is the marketing of Muzaffarpur. Thank you very much, sir. You all talk of A, B, C, D of diabetes. I am going to talk of C of diabetes. And this is the molecule which you all discussed at length. This is the insulin molecule. You all know that it's a A and B chain which is connected by the C chain. This is the C chain which we are going to talk in focus. This is the C peptide. The connecting peptide or the C peptide is actually a short 31 amino acid polypeptide that connects both the chains A and B. Interestingly, C is produced in equal amounts to insulin, and therefore it can be used to assess the amount of insulin that is secreted in a patient who is insulin treated. Normally this is the sequence where pre-pro insulin is made and it has an A, B, C chain and a signal sequence. The signal sequence is removed, then you have a pro-insulin. When C peptide is removed, it becomes the insulin A and B chain. So why to measure C peptide and why not insulin? So you have lab parameters. No, you have no. Nowadays you have reports which show plasma insulin level. Itna hai. And then the patient will tell you, my insulin is very high, my insulin is low. So what is the importance of measuring a C peptide when you have direct measurement of insulin? So how justified is insulin measurement? Insulin, why to measure C peptide? Why? Because C peptide degrades slowly than insulin. Both of them are produced at the same equimolar. They are equimolar, they are produced simultaneously, but the C peptide degrades slowly than insulin. Insulin, on the other hand, has a significant hepatic clearance. C peptide doesn't have. So C peptide will remain in the body for a longer period of time as compared to insulin, and C peptide has a constant rate of clearance in peripheral circulation. Insulin has a variable rate depending upon exercise, depending upon the food, depending upon the type of medicines that the patient is taking. So if C peptide will be available in your blood at approximately 5 times than the insulin level. So it's very wise and pertinent to measure C peptide rather than insulin. And interestingly, exogenous insulin, which you take as a treatment, doesn't have a C peptide. So it's not going to interfere with the insulin level C peptide. So there are so many advantages of measuring C peptide, but then there are drawbacks. We are scientifically oriented people, and we must know the drawbacks and the problems before we judge anything. Renal failure in patients of renal failure, which we have a large chunk of our patients, renal failure may make estimation of C peptide inaccurate because C peptide gets metabolized at the kidney levels. And in certain situations where you have an anti-insulin antibody in your some subset of patients, both pro-insulin and C peptide can give you a false high C peptide level reading. So this is the drawback. And the other drawback is lack of standardization. So we do not have a standardized way of measurement, and availability and cost issues are always there in people in places like Muzaffarpur or in places like Bihar. How to measure? So there are various methods of measuring. You can get it measured by urine, you can get it measured by blood, you can stimulate it. You can stimulate the production of C peptide. So it's a urinary C peptide to creatinine ratio, which is called the UC-PCR. Fasting C peptide, random C peptide, which is depending upon the time of the food that you are taking measuring. And then we have stimulated C peptide, which is the mixed meal tolerance test as part of oral glucose tolerance test, as toluetamide tolerance test, and glucagon stimulation test. These are some of the different ways of measuring C peptide. Urine is a non-invasive, can be done easily, and it remains in the urine for a pretty long time, 24 hours, and the cutoff value of urinary C peptide is 0.2. So I'll be talking on urine C peptide when I talk of diagnostic, where this becomes an important tool to differentiate MODY from type 1, which Dr. B.K. Singh was just referring to. 24-hour urinary C peptide is done to just it's a kind of estimation which you do in your research tool. If you have kidney issues, if you have creatinine issues, a urinary C peptide to creatinine ratio can just adjust this, and then blood estimations can be done through C peptide in whole blood collected in EDTA vials can be done, and they remain accurate for 24 hours. But if by mistake, if you collect C peptide sample in plain vials, it will remain in the sample correctly for only 6 hours. So measuring C peptide in an EDTA sample is important. So you must know that. So these are the different levels, and I just want to tell you that it is I hope you are able to see, most of the figures are 0.2. 0.2 nanomoles per liter. So I'll come to the details of this. Which is better? In majority of clinical scenarios, if you talk of clinical scenes like our OPDs and hospitals, random testing or fasting testing is more practical, easy. Urinary C-peptide is a less invasive, easily done. But if you want to have a very accurate test, then a glucagon stimulation test is what is recommended. How do you do the glucagon stimulation test? It's like whipping a child and making him cry and making the insulin and the C-peptide come out of the blood. So before you go for a stimulation test, you have to ensure that the patient is not hypoglycemic. So if the patient is hypoglycemic, the C-peptide and the insulin levels will be less, so you will be getting a lower insulin levels. So to ensure that glucagon stimulation test is accurate, you have to ensure that the blood sugar level is more than 3.9 nanomoles per liter or more than 70, and then you inject 1 milligram of glucagon over 10 seconds and collect samples at 2, 4 and 6 minutes, and you estimate the C-peptide in these samples. Mixed meal tolerance test is a similar type of test where you ask the patient to have a fixed amount of liquid mixed meal, which we call Sustacal or Boost, and this is given in the fasting state, and you measure the blood samples at 90 and 120 minutes. These are the different methods, but the point of interest today is what is the clinical utility. You will always, almost all of you must be knowing that it's used to differentiate type 1 from type 2. So we are going to take things further, and you'll make a C-peptide of diagnostic, prognostic, and as a matter of therapeutic response. So it has a huge scope of testing C-peptide in clinical settings. So diagnostic utility, of course, to diagnose type 1 diabetes, to differentiate type 1 diabetes from type 2 diabetes, to differentiate Modi. Now, Modi doesn't need any diagnostic test. He is known by his personality. But this Modi would require some tests. As Dr. Virmani said, you need genes to test. So genetic testing for Modi, but C-peptide is going to help. Which subset of patients are going to go for genetic testing? And to the help in diagnosing diabetes of adults. And then prognostic utility. So where is prognosis associated with C-peptide? So you can measure C-peptide and tell how long has this patient suffering from diabetes. So as a marker of duration of diabetes, to predict microvascular complications in type 1 diabetes associated with glycemic and HbA1c variability, and to predict the risk of hypoglycemia. Dr. Virmani would be interested in this part. As a marker of therapeutic response, lower baseline value is associated with increased need of insulin. So if you have a low HbA1, if you have a low C-peptide at the very outset of treatment, this patient is the candidate of a possible insulin. Lower baseline value is associated with shorter time to insulin therapy. So if a patient comes at 70 years of age or 65 years of age, and you do a C-peptide, and if the C-peptides are low or very low, you can just predict that this patient might be requiring insulin in a short period of time. Higher values predict better response to oral anti-diabetic, especially metformin and insulin secretagogues like sulfonylureas, and higher values would predict good response to thiazolidinediones. It also correlates with HbA1c reduction in patients treated with GLP-1 receptor agonists, which is the blue-eyed baby of today's diabetes management. So where is diagnostic utility of C-peptide? So in insulin-treated patients, if the fasting C-peptide level is less than 0.2 nanomoles per liter, or a glucagon stimulation test is less than 0.32 nanomoles per liter, this has been strongly correlated with type 1 diabetes. Of course, there is a honeymoon period of type 1 diabetes where some amount of insulin secretion is left. So that if you rest aside the other this honeymoon phase, these levels are quite sufficient to label a patient to be having a type 1 diabetes. Of course, you need an anti-GAD antibodies and the other antibodies to label these patients as type 1 diabetes. Now, how do you differentiate type 1 diabetes from type 2 diabetes as far as C-peptide is concerned? So the cutoff value of fasting C-peptide is 0.2 and the GST, which is the glucagon stimulation test, not the good and sales tax, the GST is 0.6. And how do we do that? So this is the algorithm. So if the patient is having a C-peptide of more than 0.5, rest aside that this patient is having a type 2 diabetes, just on your right side of the slide. And on the extreme left, you see a C-peptide of less than 0.2. So if the patient is having a C-peptide of less than 0.2, you ask for a sustacal or a mixed meal tolerance test or the glucagon stimulation test. And if it is still less than 0.2, you can be very sure that this patient is having a type 1 diabetes. Now suppose the patient is having a value between 0.2 to 0.5, you set the history of the patient. If the patient is having diabetes for more than 30 years and if the patient's value is between 0.2 to 0.5, label these patients as type 2. And if the duration is less than 30 years, so you have to go for stimulation tests. And again, if the stimulation tests are less than 0.2 or between 0.2 to 0.5, you can label fairly accurately that this patient is having type 1 diabetes. And if these values or the duration is more than 30 years, you can be very, very sure that these patients are having type 2. So this algorithm is going to help you in classifying type 1 from type 2 as far as C-peptide is concerned. As far as MODI is concerned, MODI, there are different types of MODIs and there are two very specific type of MODI, which is the HNF 1A and 4A, where some amount of insulin secretion is left with this subset of patients. And if the urinary C-peptide to creatinine ratio, I was just referring you the UCPCR, if it's 0.2 nanomoles per liter, 5 years post-diagnosis, it has a 97% sensitivity and 96% specificity for differentiating HNF1A and HNF4A MODI from type 1 diabetes. Even a random C-peptide level of 0.2 nanomoles per liter in patients under 30 years of age and more than 3 years of duration is a criteria for considering MODI testing. So you can go for genetic testing only when you have done a C-peptide. So it's a stopgap arrangement. You cannot ask all patients to go for a genetic testing. So C-peptide is an easy test you can recommend from your labs, and there are labs which are doing it frequently. So it's going to help you in approaching the diagnosis of MODI. Now diagnosing LADA, of course, LADA is a type of type 1 diabetes where the patient is having very low C-peptide levels. And if very low C-peptide level is associated with antibodies, positive antibodies, you can very well be sure that if this patient is having LADA if the presentation is more than 25 years of age. Differential diagnosis of hypoglycemia. Now, if the patient suppose takes overdose of insulin, so what happened? C-peptide values will be low in a person if the patient has taken an overdose of insulin. But suppose the person is having insulinoma or the patient is having sulfonylurea levels, the C-peptide would never be suppressed. So in insulinomas, you will have a very high C-peptide levels. So you can very well differentiate hypoglycemia causes, whether it's hypoglycemia because of insulinoma or it's because of insulin. So in insulin, the C-peptide levels may be suppressed. As far as prognostic utility is concerned, we all live and vouch by DCCTs. DCCT was a trial for type 1 diabetes which showed convincingly that a tighter control is going to prevent microvascular complications, and we vouch for DCCT every time. All our presentations, all our key speakers talk of DCCTs. Do you know that DCCT, I'll take 5 minutes more, sir, if you allow. Dr. Shawal says stop it, 2 minutes. So if you take DCCT trial, No, the time shows 17 minutes more, so I have a 17 minutes more. So DCCT, the admission criteria was a C-peptide level. You know this. A C-peptide of glucagon stimulation test, if it was less than 0.5, these patients were recruited for type 1 for DCCT trial. And they used intensive continuous insulin infusion and multiple insulin infusions, multiple insulin injections in those subset of patients, and thereafter they found that a tight control had a good microvascular prevention of microvascular complications. So prognostic utility of C-peptide is also there. A person who is having absolute insulin deficiency measured by C-peptide levels is more likely to go for ketoacidosis, microvascular complications and hypoglycemia. How do you label absolute insulin deficiency as far as C-peptide is concerned? So if the C-peptide is less than 0.2 nanomoles per liter in the glucagon stimulation or a mixed meal test, and if it's less than 0.08 nanomoles per liter in fasting state, it's an absolute insulin deficiency. So as a marker of therapeutic response, so if all patients with a GST of less than 0.2 nanomoles are likely to have an absolute requirement for insulin. So you can monitor C-peptide and you can predict that this patient is going to have advantages of oral anti-diabetics or insulins. Predicting insulin withdrawal in type 2. It's a very attractive for patients. I want to stop my insulin. Sir, मेरा insulin बंद कर दीजिए, मुझे दवा दे दीजिए. So this is a very attractive option for patients, but very, very challenging for the clinician. So C-peptide falls in here. There have been multiple trials. Now let's see one trial, the first one, the Japanese trial, where patients, 69 Japanese patients who were antibody negative type 2 diabetics, who had an HbA1c of 7.4, receiving complex insulin therapy for more than 1 year, they asked themselves to get removed from insulin. So the C-peptide threshold which was recruited in these patients was 0.97. And these patients were stopped insulin and they were switched over to oral anti-diabetics. So these patients had 82% successful insulin withdrawal, had HbA1c less than 7% at 12 weeks. So C-peptide is going to help you making a judgment whether you are valid in stopping insulin in subset of patients. And these subset of patients do well even on oral anti-diabetics. So it's going to help you in your regular treatment plan also. You can predict insulin regimens and you can, please summarize, please. Predicting responses to OADs as well. So to conclude, let me give you two figures only. A stimulated C-peptide level of less than 0.6 nanomoles, a fasting less than 0.25 nanomoles, a post-meal use PCR of 0.6 nanomoles are suggestive of marked insulin deficiency and possibly type 1 diabetes. A stimulated blood C-peptide of less than 0.2 nanomoles per liter, a fasting C-peptide of less than 0.08 nanomoles per liter, a post-meal UC-PCR of less than 0.2 confirms absolute insulin deficiency, and these are the subset of patients who require insulin. So C-peptide has multiple clinical implications. We need to wake up and utilize this C-peptide in our usual clinical practice. Thank you very much.
You have covered the entire spectrum of C-peptide. I'll just ask you a very simple clinical question. You have a patient of 20 years who comes to you asymptomatic, normal weight, no signs of insulin resistance. His fasting blood sugar is 350, postprandial is 480. And you decide you want to know whether it's type 1 or type 2. So you send a C-peptide and it comes to 0.1. Will you label him as type 1?
No, sir. No, sir. So there is a catch here. So a patient who has a very high sugar will always give you a false low C-peptide. So before jumping onto C-peptide, you need to bring the insulin sugar levels to normal. Wait for 2 or 3 weeks and then recommend C-peptide. And there only you will be able to understand the actual status of his insulin secretion. And then you can make a judgment.
Excellent. I knew you would answer this question, so I asked you.
Thank you.
So it is very important to realize, never do C-peptide when the blood sugar is very high. Get it under control with the insulin, with whatever, and then do a C-peptide if you really want to know what is the value of C-peptide. Yes, Supriyo.
And if you really want to know the type 1 or type 2, get a garden. Get a garden. Get a
Thank you for gagging us. That's a bit too much, going too far. But then even there also you need a stimulated C-peptide, not only a one thing, unless it is very undetectable. So but the main message I wanted to give was, people, you know what they do is, they send the C-peptide on the same day, it comes down and they put the patient insulin permanently. Right. So that is a clinical tip you must remember. Get the blood sugar down and then do a C-peptide. Right, straight away.
Right.
Thank you.
Thank you very much, sir. I think the only message is C-peptide is important, not only in differentiating, but also in
and you should also know when to do it.
Yeah, thank you, sir. Thank you very much.
I think we'll close the session here and give mementos to the speakers.
May I request the first speaker in this session, Dr. B.K. Singh sir, also to please come on the stage. May I request the chairpersons to honor Dr. B.K. Singh sir with a bouquet. हो गया सर, ये डॉक्यूमेंट सर, and I request chairpersons to and request chairpersons to honor Dr. Amit Kumar Das. He has given a wonderful talk. And request chairpersons to honor the speakers will honor the chairpersons in turn now. Dr. Anil Kumar Virmani sir. And a bouquet for other two chairpersons, Dr. Shehbaz sir and Dr. Kamran Khan. Another bouquet for He is the spine behind the conference here. Let's big hand for all the speakers and the chairpersons. Thank you so much. Moving on to the next session, may I request chairperson for the next session, Dr. Anuj Maheshwari sir, Professor Dr. D.P. Singh sir, and Dr. Sadiq. Please come on the dais.